Hello everyone, a very good morning to all of you. I hope I am clearly visible and audible to you guys. Am I? If I am clearly visible and audible to you, please give me a thumbs up in the chat box. Okay, I guess it's working and I am clearly visible and audible to all of you. So a very good morning to all of you. I welcome you all for today's session. I am Dr. Priyanka Sachdev here and today I am here to teach you renal system pathology. Now, renal system is one of the complicated systems in which students find difficulty in understanding the various diseases, various pathologies. So, I will be teaching you first of all the most important pathology in renal system, the various type of glomerulonephritis in a super simplified manner, in a comparative manner. So, I will teach you everything about glomerulonephritis. But before jumping on the pathology that is glomerulonephritis, it's important to understand the anatomy of the kidney, the anatomy of the nephron, what is the structure of the glomerulus, without which you cannot understand glomerulonephritis, and the physiology of urine formation. So in the first 5 to 10 minutes, a little bit about the anatomy, physiology and histology, normal histology. Then it will be easy for you to understand the diseases. Can I start now? Can I start? Give me a thumbs up. So here you can see in this diagram, humans have a pair of kidney. So in this diagram, you can see kidney are the bean-shaped organ and all humans, I guess, have a pair of kidney. On the medial surface of the kidney, there is a point at the midpoint of the medial surface of the kidney. This point is known as hilum of the kidney. At the hilum of the kidney, renal artery enters into the kidney. Renal vein comes out of the kidney and ureter comes out of the kidney and lymphatics are present. So you can see this is renal artery entering the kidney, renal vein coming out of the kidney, ureter coming out of the kidney and lymphatics are present. So this point is very important in the kidney and it is the known as hilum of the kidney. So after that you can see this is a kidney. Inside the kidney, the structural and the functional unit of the kidney is a nephron. So can you appreciate a nephron? Yes. So inside each kidney, nearly 1 million nephrons are present. So humans have a pair of kidneys. So nearly humans have, normal healthy human beings have 2 million of nephrons. And nephrons are the structural and functional unit of kidney. So let me show you the diagram of a nephron before coming on the various pathologies. So you can see in this diagram, we can see a nephron. Can you see a nephron? Yes. So we can see the 5 portions of the nephron. What are the 5 portions of the nephron? The first portion of the nephron is Bowman's capsule. Can you appreciate this capsulated structure? This is known as Bowman's capsule. Along with the Bowman's capsule, the tuft of capillaries present inside the Bowman's capsule. This is known as glomerulus. So the first structure of the nephron is glomerulus. So today I am going to teach you the various type of glomerulonephritis. I will be teaching you all type of glomerulonephritis, the primary one, the secondary one, the hereditary one. So before that, you must understand the structure of the glomerulus. So that the inflammation of the glomerulus will be glomerulonephritis, itis. It is the inflammation of the glomerulus, right? The second portion of the nephron is the tubule. It is known as proximal convoluted tubule, that is PCT. You can see. The third portion of the nephron is loop of Henle. You can appreciate this is loop of Henle having 2 limbs. The first limb is the descending limb and the second limb is the ascending limb. Can you see? The fourth portion of the nephron you can appreciate here is DCT, that is distal convoluted tubule. And the last portion of the nephron you can appreciate here, it is collecting duct. Now, these 4 portions, that is PCT, loop of Henle, DCT and collecting duct, that is this all portion apart from glomerulus, this is known as tubules. These are known as tubules. So, we have glomerulus in the nephron, we have various types of tubules in the nephron and the background. Can you appreciate the background? The background around the tubules. This is all background around the tubules. This background is known as interstitium. So in kidney, various types of diseases. Basically, 4 types of diseases are present inside the kidney. So when the diseases involve the blood vessels of the kidney, can you appreciate? Here are the blood vessels. So it is known as vascular diseases of the kidney. The diseases which involve the glomerulus of the kidney are known as glomerular diseases, that is glomerulonephritis. The diseases which involves tubules of the kidney are tubular diseases, and the diseases which involve interstitium of the kidney are interstitial diseases. Now, usually tubules and interstitium are always involved together. That's why we have a combination tubulo-interstitial diseases in the kidney, right? So after that, let me move ahead. So we have already seen the 5 portions of the nephron. You can see the first portion of the nephron is glomerulus, the second is PCT, then loop of Henle, then DCT, then collecting duct. And nephrons are the structural and functional unit of the kidney. Now you have seen the diagram of the nephron. Let me have an overview on the anatomy of the kidney and move ahead on the topic, that is glomerulonephritis. Now in the kidney, we can divide the kidney into 3 portions: cortex, medulla and pelvis. So here you can see in this diagram of the kidney, you can appreciate the 3 structures of the kidney. The outermost is the cortex. Can you appreciate the outermost thin rim? This outermost thin rim, 1 centimeter thin rim, this is cortex. This is cortex. This portion is medulla, the middle one. And the innermost, this yellow portion, is the pelvis. So we can divide the kidney from outer to inner into 3 portions. The outermost thin rim is cortex. The middle one, in which these pyramids are present. So pyramids are present in the medulla. This is entire medulla having multiple pyramids. And the innermost yellow portion you can see here, that is the pelvis. Now, nephrons are present. Where the nephrons are present in these? The nephrons are basically present in cortex. The nephrons, all the 1 million nephrons are present in the outermost one rim. Outermost 1 centimeter thin rim of the kidney. All the neurons are present. All the nephrons are present. So cortex is about 1 centimeter thick. It is the outermost rim of the kidney. You can appreciate the outermost rim. It is the cortex, right? So that is the cortex we have seen. Now let me cut a section of the kidney from here. If I cut the section of the kidney from here, I can see this is outermost cortex. This one, this portion is outermost cortex, you can see, and the inner portion is the medulla. You can appreciate this inner portion is the medulla. So in this diagram, you can see this is outermost cortex I am talking about, and this is inner medulla I am talking about. So outer, this one is cortex. From here to here, it's cortex, and this portion is medulla. You can appreciate this portion is medulla, this portion is cortex. So I hope you got it. What is cortex? Now, based on the location of the nephron, nephrons in the kidney are of 2 types. I have told you inside the kidney 1 million nephrons are present. So where they are present? Where? Now there are, now see this diagram. You can appreciate the cortex and medulla with change in color. Yes. Now there are some nephrons. The complete nephron is inside cortex only. All the 5 portions of the nephron is inside cortex only. Can you appreciate this nephron? So you can see this is the glomerulus, this is PCT, this is loop of Henle, this is DCT, this is collecting duct. All the 5 portions of the nephron is inside cortex only. Such nephrons are known as cortical nephrons because the complete nephron is present inside the cortex, right? So such a nephron is known as cortical nephron. Now see this nephron. I am marking another nephron for you. Can you appreciate this one, this nephron, in which glomerulus, PCT, DCT and collecting duct, these are present in cortex, but the loop of Henle is going in medulla. Only loop of Henle is going in medulla, not in cortex, in contrast to loop of Henle of the other nephron in which everything was in cortex. Here loop of Henle is going in medulla. Such a nephron is known as juxtamedullary nephron. So juxtamedullary nephrons are the nephrons in which glomerulus are still in cortex, but the tubule, the loop of Henle, is going in the medulla. So basically, summary is that all the nephrons, 100% of the nephrons, glomerulus lie in the cortex only. Whether the nephron is cortical or whether the nephron is juxtamedullary, the glomerulus is always in the cortex of the kidney. Now, depending on the type of the nephron, tubules may be in cortex, maybe in medulla, but 85% of the nephrons are cortical out of total 100%, in which the complete nephron is in the cortex, and 15% nephrons are juxtamedullary nephron, in which loop of Henle is going in the medulla. Give me a thumbs up in the chat box if you got the meaning of the 2 type of nephrons. These are the basics, I guess you know. So you can appreciate the 2 type of nephrons here. Can you appreciate? The first type of nephron is cortical nephron, which are 85% of the total nephron, in which glomeruli as well as complete tubules lie in the cortex only. The complete nephron is in the cortex only. On the contrary, the other type of the nephrons are juxtamedullary nephrons, which are nearly 15% of the nephrons, in which nephrons send their loop of Henle. The loop of Henle are going in the medulla. Give me a thumbs up if you got the 2 type of the nephron. Now coming on the second portion of the kidney is medulla. You can see just below the cortex, this is medulla. Let me draw the boundary. Let me draw the boundary of the medulla. So medulla is starting from here and ending here. Can you appreciate? So inside the medulla, you can appreciate multiple pyramidal structures are present. These pyramidal structures are known as renal pyramids. These pyramidal structures are known as renal pyramids, and renal pyramids are present inside the medulla. Now the tip of the pyramid, can you see the apex of the pyramid? The apex of the pyramid is known as papillae. So whatever urine or filtrate or urine formed here, it will be sent into the pelvis of the kidney via these papillae. So can you see? So inside the medulla, there are multiple pyramids. These pyramids are known as renal pyramids. The apex of the pyramid is known as renal papilla, the opening for the urine into the pelvis. So we have seen medulla also, we have seen cortex also, medulla also. Right, now you can see between the adjacent pyramids, the portion of the kidney, between two adjacent pyramids, this portion of the kidney, this portion of the kidney, this portion, between two adjacent pyramids, the portion of the kidney, it is known as renal column of Berlin. It is known as renal column of Berlin. Can you see the renal column of Berlin? So it is an MCQ. You know what is renal column of Berlin? So you can appreciate renal column of Berlin. It is the column of renal tissue between adjacent pyramids. So that is renal column of Berlin. After that, coming on the third portion, that is pelvis. Can you see the yellow color portion in this diagram? Let me go to the diagram. The yellow color portion is the pelvis. Now in the pelvis, there are calyces. Can you see? 1, 2, 3. This one is fourth one, fifth one, sixth one, seventh one. In this diagram, I can see 7 minor calyces. All these are minor calyces. So pyramids are opening in minor calyces. So these are known as minor calyces. So how many minor calyces are there in this diagram? And how many normally are present in a kidney? So let me show you. There are 8 to 18 minor calyces. So in this diagram, we can see 7 to 8 in number. And minor calyces open in major calyces. So you can appreciate these 3 are opening in this structure. These 3 are opening in this structure. And these. So these are the few major calyces. So minor calyces open in major calyces, and major calyces opens in ureter. So ultimately, this is how ureter of the kidney is formed. So whatever urine formed here in the nephron, I told you 1 million nephrons are present here in the cortex. So in the cortex, the glomerular filtration is formed. After that, urine is formed. So urine goes in the pyramid, that is in medulla. From the pyramid, it is coming into the minor calyces. From minor calyces, it is coming to major calyces. And from major calyces, it comes to the ureter. So, and from ureter, of course, it will go to the bladder, and it will void it out of the body through urethra. So this is the complete pathway how urine formation takes place. Now, I will teach you the complicated topic glomerulonephritis today. Glomerulonephritis, itis, it is the inflammation of the glomerulus. You cannot understand glomerulonephritis if you don't understand the structure of the glomerulus in a nephron. Now you know what is kidney, you know what is the structural and functional unit of the kidney, that is a nephron. Inside the nephron, we are having 5 portions, you already know that. The first portion of the nephron is the glomerulus. Now let me teach you the structure, which is very complicated, the structure of the glomerulus. Once you got the structure of the glomerulus, it will be easy for you to understand the inflammation of the glomerulus, so that the disease glomerulonephritis will become very easy, or it will become fun for you. So let me teach you glomerulus. So what is glomerulus? I guess everyone knows that this is glomerulus. So in this glomerulus, can you see that this is the artery entering inside the glomerulus? This is known as afferent arteriole. Afferent arteriole, this is Bowman's capsule. This yellow color structure, it is a capsulated structure. It is the Bowman's capsule. Now inside the Bowman's capsule, afferent arteriole comes. It enters, form multiple capillaries, tuft of capillaries. Can you appreciate these multiple tuft of capillaries are there? A bundle of capillaries are there, and then exit out, drain out in the form of efferent arteriole. So first afferent arteriole is coming, forming a tuft of capillary, and exit out as efferent arteriole. Have you got it? Give me a thumbs up if you got it. So okay, so this is the thing. So, and after exiting out, what happens to this efferent arteriole? Can you see this efferent arteriole? Once it exits out, after that, it will form a bunch of capillaries over the tubules. The bunch of capillaries over the tubules, that is the continuation of the efferent arteriole. This is known as peritubular capillaries or vasa recti. So this is the normal structure, vasa recti or peritubular capillaries, that is formed by the efferent arteriole once come out of the Bowman's capsule. So okay, in this diagram, you can see the vasa recti. Can you see in this diagram? Please everyone appreciate, this is afferent arteriole. This one is afferent arteriole. It is entering inside the Bowman's capsule. Appreciate the Bowman's capsule first. After entering in the Bowman's capsule, it is forming multiple tuft of capillaries, and then it exits out in the form of efferent arteriole. After exiting out in the form of the efferent arteriole, this efferent arteriole form a bunch of capillaries over the tubules. By tubules, I mean four things. That is proximal convoluted tubule, PCT, loop of Henle, DCT, and collecting duct. So the efferent arteriole forming a bunch of capillaries over all the tubules, it is known as vasa recti or peritubular capillaries. So here also you can appreciate this is renal artery. Can you appreciate this is renal artery? From the renal artery, this is afferent arteriole coming out. It is entering inside the Bowman's capsule. Appreciate the Bowman's capsule. After entering inside the Bowman's capsule, it is forming a tuft of capillaries. And then it exits out in the form of the efferent arteriole. Once efferent arteriole exits out of the Bowman's capsule, it will form a tuft of capillary over the tubules, that is vasa recti. I guess everyone got it, right? Now, before understanding glomerulonephritis, what is glomerulonephritis? It is the inflammation of filtration barrier inside the glomerulus. So you must ask me, ma'am, what is this filtration barrier inside the glomerulus? Okay, so look at this diagram. I will zoom this portion for you. You can understand this diagram. You can see this is Bowman's capsule, right? You can see this is afferent arteriole entering inside the Bowman's capsule. It is forming multiple tuft of capillary. I will draw only one to explain you. And then it exits out in the form of efferent arteriole. Let me zoom this structure for you. So can you see in this diagram what I have drawn? You tell me. In this diagram, you can appreciate this is the Bowman's capsule, the blue one. This one is the Bowman's capsule, which is continued as PCT. So Bowman's capsule is continued as PCT. We can see. So this is the Bowman's capsule. Now please give me a thumbs up. Have you got it? Have you got it? Gaming, have you got it? Others, Anu, have you got it? This is the Bowman's capsule continued as PCT, right? Now this is the afferent arteriole. Can you appreciate? It is the afferent arteriole entering inside. I have drawn only one tuft of capillary. It is forming one tuft of capillary. Can you see? It is forming one tuft. There are multiple, but for the sake of understanding, we have drawn only one capillary loop. And it exits out in the form of efferent arteriole. So this is afferent arteriole entering, forming the capillary and exit out as efferent arteriole. Is there any problem in understanding that? I guess no. There is no problem in understanding that. Now, whatever blood is entering in the afferent arteriole, the blood is entering here in the afferent arteriole. Whatever substances present in the blood, here are the substances present in the blood, which are supposed to get excreted, in the urine, they will get filtered here. Glomerular filtration. They will get filtered here and they will accumulate in Bowman's space. This space is known as Bowman's space. Do you have problem in understanding that? I guess no. So whenever the impure blood is entering in the afferent arteriole, you can see the impure blood. Now in the blood, these are the vestigial products. It can be uric acid, it can be urea, it can be BUN, it can be creatinine, it can be other vestigial products. The metabolic waste is present in the blood. The body want to excrete the metabolic waste. So all the substances which are supposed to get excreted, they will get excreted in urine, right? They will get filtered here, right? And get collected here. Now the liquid, the filter which is collected here, it is known as glomerular filtrate. We will not call it urine right now. We will call it as a glomerular filtrate. Do you have any problem understanding that? I guess everyone got it. Now, my point, what is my point here? My point, these substances which are filtered here, they have to cross a membrane here before coming from the blood into the Bowman's space. The substances which are leaving the blood and coming in the Bowman's space, they have to cross a barrier in between. They have to get filtered from this barrier, and this barrier is known as filtration barrier. Now tell me the layers of the filtration barrier, what they have to cross. You got my point? You got my point? So what they have to cross? So these substances have to cross 3 layers. Here 3 layers are present, right? So there is a basement membrane of the capillary. This is a capillary now. So this is afferent arteriole coming, forming multiple capillaries. It is one of the capillary. All capillary have basement membrane. So this is a basement membrane. So the first thing is the basement membrane, right? So the first thing is basement membrane. On the inner side of the basement membrane, this is the endothelial lining. Because all capillaries are lined by endothelium, all blood vessels are lined by endothelium. So capillary is also lined by endothelium. So this is the endothelium lining. So there is a basement membrane. On the inner side, there is endothelium. Endothelial lining, the capillary, right? Now, what is the lining of the Bowman's capsule? Do you know the lining of the Bowman's capsule? The Bowman's capsule is lined by 2 types of epithelia. This epithelia I am drawing with green color. Can you see? This one, the Bowman's lining. This is the first epithelia I am drawing with green color. And let me use another color, red color. I'm drawing the another epithelia by this color. This is another epithelia. So the Bowman's capsule is lined by two different type of epithelium. In this diagram, the green one, can you see the green one? The green one is known as visceral epithelium. Visceral epithelium, absolutely right, Sai Lakshmi. It is also known as podocyte. I will tell you the reason why it is known as podocyte. It is visceral epithelium. And the outer one, the red one, can you appreciate the red one, the outer one? This is known as parietal epithelium. Parietal epithelium. Now you tell me that while a substance, this is the metabolic waste, while it is crossing the blood vessel and entering in the Bowman space, what three layers it has to cross? The three layers which it has to cross is forming the barrier that is known as filtration barrier. So you will say, ma'am, in the center there is a basement membrane. On the inner side of the basement membrane there is endothelium of the capillary, endothelium, and the outer surface of the basement membrane there is epithelium of the Bowman's capsule. Which epithelium? It is visceral. So the parietal one is here. Parietal to bahar ki covering hai. That is not crossed by the metabolic waste. So metabolic waste is crossing three layers. What is the sequence? First endothelium, then basement membrane, then visceral epithelium. The visceral epithelium is known as podocyte. First, everyone give me a thumbs up. You got my point? So the same thing. So here in this diagram, this is the capillary. Again, see, this is the afferent arteriole entering. This is afferent arteriole entering. And it is forming multiple capillaries. Let me draw one of the capillary. So can you see in this diagram, this is one of the capillary. All capillaries have two things. Number one, the basement membrane. And number two, the inner lining of the capillary is endothelial cell. The red cells are the endothelial cells. Can you see the basement membrane and the endothelial cells are present? So this is the capillary which is present inside this Bowman's capsule. I have drawn this capillary separately to explain you the lining of the capillary. Now appreciate the same lining, the two things, basement membrane and endothelium here. Can you appreciate? I guess everyone can understand. So the black color is the basement membrane of the capillary. Give me a thumbs up. And the inner red color cells are the endothelial cells. So basement membrane and endothelial cells are there. Now let me come on the lining of the Bowman space. As I have told you, in Bowman space, two types of cells are present. The green one is the visceral epithelial cell, and this purple one, the outer one, this one, the outer one, these one. The outer one, can you see the outer one? This one, the outer one is the parietal. Have you got it? This green one is the visceral, green one. Now you tell me that when a substance, this is a substance. Let me show you one of the substance. So imagine one of the metabolic waste is present here. I don't know why the pen is not working. Okay, this is one of the metabolic waste. Can you see? It has to cross. It has to get excreted in urine. So it has to cross the filtration barrier. So can you see the three layers it is crossing? Tell me the three layers in sequence. What are the three layers in sequence? This metabolic waste has to cross while coming out of the blood into the urine. So this is the yellow color dot is the metabolic waste. It can be urea, BUN, creatinine, anything. It has to get excreted in urine. So it has to leave the blood and go in the urine. So it has to cross a barrier. So in the barrier, three things are there. So can you see in the center, basement membrane is there, right? In the center, there is basement membrane. On one side, inner side of the basement membrane, there are endothelial cells. And on outer side of the basement membrane, there is epithelial cell. To be specific, this epithelial is visceral epithelial, not parietal epithelial. Everyone give me a thumbs up. Have you got it? So these three things, the triad, the three things, the triplet is known as filtration barrier. In the filtration barrier triplet, there is the basement membrane in the center. On the inner side, endothelium. On the outer side, epithelium. Epithelium is visceral epithelium, that is podocyte. I guess it is crystal clear to all of you, right? So this is the same labeling done in front of you. You can see the labeling. You can appreciate the three things which are present in the filtration barrier. So in the center, there is basement membrane. On the inner side, endothelium. On the outer side, it's epithelium. It's visceral epithelium, which is known as podocyte. Parietal epithelium is not a part of the filtration barrier. You can appreciate this is parietal epithelium. The outer covering of the Bowman's capsule, the purple one here shown, I'm marking here. So this is not a part of filtration barrier, but yeah, it is present. So I guess everyone got it. What is filtration barrier? Give me a thumbs up if you got it. What is filtration barrier? Okay, just a second. Okay. So let me draw a filtration barrier for you. Just a second. Okay. So in the filtration barrier, you can see in the center, there is a basement membrane. In the center, there is the basement membrane. On the inner side of the basement membrane, these are endothelial cells of the capillary. These are endothelial cells of the capillary, and on outer surface of the basement membrane, these are epithelial cells. These are epithelial cells of the Bowman's capsule, the green color cells. These are visceral epithelial cells. Now, why they are known as podocytes? Podo का मतलब क्या होता है? What do you mean by podo? Podo means human foot. See your foot. What is the shape of your foot? Can you see your foot? The shape of human foot is somewhat like this. So there is the toe and the four fingers. So see the shape of these cells. The shape of these cells is more or less like the human foot. Since it is same as that of human foot, these are known as podo. Podo means human foot. Podocyte. Cyte means cell. So the cell resembling the foot, that is podocyte. So that is because of their shape, they are known as podocyte. But actually they are epithelial cells, the visceral epithelial cells. Everyone give me a thumbs up. Everyone. So this is filtration barrier. In the center there is basement membrane. On the inner side there is endothelium. On outer side there is epithelium. Epithelium is visceral, not parietal, and due to their shape resembling the human foot, it is known as podocyte. I guess the concepts are, if the concept now in all glomerulonephritis, now today I'm going to teach you nearly 20 or 25 different type of glomerulonephritis. I will teach you all primary, all secondary, all hereditary, all congenital, all type of glomerulonephritis and the differences between them. Now in all the glomerulonephritis, one thing is common, the inflammation of the glomerulus. Glomerulonephritis, itis in pathology is the inflammation of that particular tissue. So glomerulonephritis is the inflammation of the glomerulus. Inside the glomerulus, the filtration barrier get inflamed. This triplet get inflamed. So actually it's the inflammation of the filtration barrier. So actually it's the inflammation of the Now in this diagram, the same filtration barrier is shown. Now let me show you this diagram. This is the basement membrane in the center. Please appreciate the basement membrane is in the center. Can you appreciate on one side, these pink color cells are the endothelial cell. On one side, you have to draw endothelium, and on other side, you have to draw visceral epithelium. So please appreciate on other side, these are the epithelial cells. These are the epithelium. Now see the shape of this cell. It is looking like a foot. It is looking like a foot. That's why it is known as podocyte. So now one more thing. In the basement membrane, there are three portions. Can you appreciate the three things in the basement membrane? If you see the zoom version of the basement membrane, that is electron microscopy of the basement membrane of the glomerulus, you will find it is divided into three portions. The central portion is dark and the peripheral two portions are light. That's why the central portion of the basement membrane is known as lamina densa, and the peripheral two portions which are lighter in color, they are known as lamina rara. They are known as lamina rara externa and interna. Everyone give me a thumbs up. So this is actually filtration barrier. This is actually, now see the electron microscopy diagram. In the electron microscopy diagram also, you can, just a second, you can appreciate the same filtration barrier. I have to go back. You have to wait for a while. Unable to go back. Yeah, here in this diagram. Can you see this is the filtration barrier? If you can appreciate that in this filtration barrier, please appreciate the central portion which is darker. The central is darker and the peripheral two are lighter. So the central darker portion is lamina densa and the peripheral two lighter portions are lamina rara, lamina rara, lamina rara externa, lamina rara interna. Have you got it? Now in this you can appreciate on one side of this basement membrane, I guess this one is the endothelium. This one is the endothelium which is flattened, relatively flattened. And on other side of the basement membrane, you can appreciate the epithelial cells. The visceral epithelial cells, the podocytes, see the shape. The shape is like the fingers of the foot. So these are the foot processes, known as foot processes of the podocyte. The fingers are known as, now appreciate the triplet, appreciate the filtration barrier. Now when I will teach you various type of glomerulonephritis, so in each type of glomerulonephritis, I will tell you there is inflammation of the barrier, but which portion of the barrier? Is there is inflammation of the basement membrane? Is there is inflammation of the podocytes, or is there is inflammation of the endothelial cells? So various type of immune complexes I will teach you. The location will be different in each of them. So let me move ahead. You got it. What is the filtration barrier here? I guess the triplet. We all understand what is this triplet about. Now let me move ahead. Now this is the diagram. This is the master diagram today. In this diagram, I am going to teach you all glomerulonephritis today only. Today we have a marathon for renal system. I will complete all glomerulonephritis today only. So whatever is the time, right? So we will take various episodes 1, 2, 3, 4 and finish entire glomerulonephritis renal system today only, right? Now this is the master diagram. In this is from Robbins, a beautiful diagram. You can see if I'm cutting the glomerulus from here. Give me a while. If I'm cutting the glomerulus from here, imagine if I'm giving a cut here and looking it from above, how does it look like? If I'm giving a cut here and looking from above, the cross section from the above, it will look like this. It will look like this. So what is it? So there are multiple capillaries, not one. So can you appreciate these are? So how many capillaries are shown? Capillary number 1, capillary number 2, capillary number 3, capillary number 4. I guess in this diagram, 4 capillaries are shown. Can you see? I'm cutting the glomerulus from here. I'm giving a cut from here and looking from above. So it is looking like this. So this is the diagram which I can see if I'm giving a cut and looking from above. So there are multiple capillaries, not one. For the sake of understanding, we have drawn one in that diagram. But these are the multiple capillaries, right? In these multiple capillaries, in each capillary, appreciate the triad, appreciate the filtration barrier. So please appreciate, can you see this orange color fenestrated lining on the inner surface of each capillary? On the inner surface of each capillary, this orange color fenestrated lining, this is endothelium. This is endothelium. The lining which I have marked with this black color, this is basement membrane, and the outer surface, these are podocytes. These are actually the foot processes of the podocyte. These all are podocytes. These all blue color cells are podocytes. So you can appreciate the triplet everywhere. The triplet is the filtration barrier. So basically we are having multiple capillaries. The inner surface is lined by endothelium. The outer surface is lined by podocytes or epithelium. In the center there is a basement membrane. This is the summary we all got till now. And these multiple capillaries are there. And can you tell me what are these yellow color cells? Anyone? You can write in the chat box if you know the answer. The yellow color outer cells which are bounding everything, which are forming the boundary of the complete thing. The yellow color thing, this outer thing here, which are giving the boundary to everything. Can you tell me? Sachin, Arvind, Sai Lakshmi, Aishwarya, anyone who is watching me, gaming, who is watching me live. Can you tell me what is this thing? It is, yes, it is parietal Bowman's capsule, parietal epithelium of the Bowman's capsule. I am talking about this one. So it is the complete covering, that one, the parietal, that is not coming in the filtration barrier, but yeah, it is present. So can you see this one, the yellow cells? Yes, very good gaming. It is the parietal epithelium of the Bowman's capsule. Okay, we got it. What is this? Now the last thing, the green color cell. In the center, there are few green color cells. Can you tell me what are these green color cells? Arvind, gaming, what are these green color cells? Sachin, what is it? Yes, what are these green color cells? These green color cells are the fillers. As I have told you, multiple capillaries are there. The space between multiple capillary 1, 2, 3, 4, whatever capillaries are there, the space between them is filled by supporting cell, the filler cell. These are known as mesangial cells. So these green color cells here are the mesangial cells. Have you got it? These are mesangial cells. The green color cells are the mesangial. So this is the complete diagram of a glomerulus. Actually, on microscopy, this is the diagram of the glomerulus. Can you see? This is the diagram of the glomerulus on microscopy. In this, one of the glomerulus is shown to you. On light microscopy, you can see this lining, this complete boundary. Can you see this complete boundary? So this is parietal epithelium, which I have marked right now. So this is complete boundary. Now inside which, see the multiple capillaries, capillary 1, capillary 2, capillary 3. So multiple capillaries are there, right? This is the basement membrane. Now see the inner lining is by red color cells, the endothelial cells. See the outer lining, it is the pink cells, that is food processes, that is podocytes or visceral epithelium. See these filler cells. The filler cells are the mesangial cells. I hope everyone got this diagram. Now if you got this diagram, I am going to teach you multiple glomerulonephritis in this diagram. You can understand this diagram. This is a diagram of a normal kidney. Now if you don't understand what is normal, how you can understand what is abnormal? If you have now understood, ma'am, this is normal kidney, this is the normal glomerulus of a kidney. Now if I show you any abnormality in that, so you can appreciate the abnormality if you know the normal. So before understanding pathology, it's important to understand the physiology anatomy and histology. That's why these are first prof subjects. Before coming to the pathology, you must know all these so that you will have a better understanding. Now let me start my disease glomerulonephritis. That was an overview. If you got how we reach on this diagram, you can understand the entire diagram ahead, right? I would like to launch only one question here from the previous year question papers based on the normal structure of the glomerulus, right? Can you answer this question? Can anyone answer this question? I guess the question is very easy. Podocytes. What are podocytes? Podocytes are the cell which are visceral epithelial cells. Where they are present? Are they present in Bowman's capsule? Are they present in PCT? Are they present in DCT? Or are they present in collecting duct? So in which portion of nephron they are present? Yes, I guess that it's a very easy question. In which portion of nephron? So podocytes are the lining of the Bowman's capsule. The inner lining of the Bowman's capsule is podocyte, that is visceral epithelium, and outer lining will be parietal epithelium. So yes, the correct answer here is A, and yes, gaming absolutely right, Arvind absolutely right. The correct answer here is A, and most of you are absolutely right. Okay, so this is a question from based on the normal structure. Now coming on the diseases of the kidney. As I have told you that we can divide the diseases of the kidney into 4 portions. So in the nephron, which portion is involved? In the nephron, if afferent and efferent arteriole along with the capillaries in between. So first afferent arteriole is coming, forming multiple capillaries and exit out as efferent arteriole. If the arterioles and capillaries are involved, it is known as vasculature disease. But currently I am not teaching you vasculature disease. If glomerulus is involved, they are known as glomerulonephritis. So I am teaching you glomerulonephritis. If PCT, loop of Henle, DCT and collecting ducts are involved, these all are tubules. So these are known as tubular diseases. And if the background is involved, it is known as interstitial diseases. Tubules and interstitial are always involved together. That's why it is known as tubulointerstitial diseases. So let me start the disease glomerulonephritis. Currently I am teaching you glomerulonephritis. Again and again I am telling you itis means inflammation. So basically it is the inflammation of the glomerulus. So it is the inflammation of the glomeruli. The disease of the glomeruli. It is also known as Bright's disease, right? So before again coming on the glomerulonephritis, let me teach you the clinical features of all glomerulonephritis in one shot. Then I will teach you individual various type of glomerulonephritis. Once let me teach you clinical features before starting the topic of overall all glomerulonephritis in one single shot only. So when I will teach you individual one, it's not necessary that in each of them I will teach you the clinical features because I am teaching you here only. So all glomerulonephritis present, just a second. Okay, no, I'm not coming on the clinical feature. I will come on the clinical feature after a while. Let me teach you the pathogenesis of glomerular disease or glomerulonephritis, which is the most difficult topic, I guess, in the entire Robbins. As per my knowledge, according to me, I found this topic very difficult, but I will explain you like with such a simplicity now that it will become fun for you. Now, as I have told you, glomerulonephritis is the inflammation of the glomerulus. Inside the glomerulus, the filtration barrier, the triplet is present. Now, you should ask me the question, ma'am, who is causing the inflammation? How the inflammation of the glomerulus is occurring? So that is the pathogenesis of the glomerular injury. So there should be some injury to the glomerulus, right? So what is the injury? Now you can understand this diagram. I guess everyone can understand this diagram. Those students who can understand this diagram, everyone give me a thumbs up. In this diagram, you can see we are cutting the glomerulus at this level and looking from above. If we are looking from above, we are finding this diagram. In this diagram, we can appreciate multiple capillary loops. We can appreciate in each capillary the triplet, that is filtration barrier. The filler cells are the mesangial cells and outermost is the parietal Bowman's capsule. We all can appreciate this diagram. If we can appreciate this diagram, now let me tell you the various ways of injury in which this triplet is injured. I will always talk about this triplet. This triplet I am talking. This triplet I am talking. This triplet. This triplet. Everywhere you can see the triplet. By triplet I mean 3 things. In the center there is basement membrane. On the inner side, this is the endothelial cells. On the outer side, these are the, can you see? These all are visceral epithelial cells. So this triplet will get injured. Now the question is who is causing injury? Who is causing injury? So injury can be caused by 3 things. One of the 3 things. Either injury is caused by antibody, humoral immunity. Humans have two type of immunity, cell mediated and humoral. In humoral immunity, antibodies are there. So either the injury to the glomerulus is caused by humoral immunity, that is antibody. So here antigen antibody complexes are formed, and those antigen antibody complexes will injure the triplet. Which portion of the triplet I will tell you. Don't worry, I will tell you everything, right? Or else the injury is caused by T lymphocytes. T lymphocytes, killer T cells. T lymphocytes will cause the injury. CD4 T cells. CD4 T cells, that is killer T cells. That is cell mediated injury. So this is humoral immunity. This is cell mediated immunity. So injury कौन कर रहा है? Injury antibody कर रहा है कि injury cell कर रहा है? Cell में कौन सा cell? Killer T cell, that is CD4 T cell. So either the injury is caused by antibody or the injury is caused by CD4 T lymphocytes. Or the third way, injury is caused by complement. Human blood have complement system. In the complement system, there are C1 to C9. 9 complements are present in blood, but they are inactive. But sometimes they become active and they cause injury to the glomerulus. Such an injury is known as alternate pathway. Alternate means complement. So there are 3 ways to injure the triplet, the filtration barrier inside the glomerulus. Either the injury is caused by antibody, humoral immunity, or the injury is caused by the cell. By cell, I mean T lymphocyte, killer T cell, CD4 T cell. That is known as cell mediated injury. And the third one is the alternate pathway, in which I mean the injury is caused by the complement. C1 to C9, 9 complements are present in the human blood. You may be knowing that. So who is causing the injury? So most complicated to understand is the antibody. How antibody? In antibody, antigen antibody complexes are formed, right? Now these complexes are formed where? Right? These complexes are formed either inside the kidney, in situ, I mean inside the kidney only. Inside the kidney, in the nephron, in the triplet filtration barrier, or they are first formed in the circulation and then coming into the kidney. What I mean, I will explain you. Don't worry. What do you mean by in situ complex formation or circulating complex formation? So antibody mediated antigen antibody complexes are formed. Antigen antibody complexes kahan banenge? Where? They are forming in the kidney directly, or first they are forming in the blood and then going to the kidney. So in situ complex is circulating complex. Okay, I will explain you. Don't worry. The things are simple if you understand. Let me draw a human body, a rough diagram of a human body, a rough sketch diagram to help you with the understanding what is actually happening. Right? A rough diagram I am just drawing to explain you the mechanism. Let me draw the 2 kidneys. These are the kidneys. Inside each kidney, 1 million nephron is present. Inside each nephron, 1 nephron have 1 filtration barrier. So in each kidney, 1 million filtration barriers are present. I am interested in filtration barrier, the triplet. पूरा चैप्टर ट्रिपलेट पे ही चलेगा. The triplet inside the glomerulus of the nephron. तो imagine करो this kidney के अंदर nephron is present. I am interested in the nephron inside the kidney. So this is the nephron. This is glomerulus, PCT, loop of Henle, DCT, collecting duct. So in the nephron, I am interested in the glomerulus. I am interested in only in the glomerulus. In the glomerulus, I am interested in the triplet. So now imagine inside these kidney, the filtration barrier is present. Multiple filtration barrier present inside each kidney. That is multiple glomerulus. Each glomerulus have 1 filtration barrier. Give me a thumbs up. Yes. So that we can imagine. Now let me draw a blood vessel here. Okay, this is the blood vessel of a person, right? This is the blood vessel. Just for the sake of understanding, I am drawing this diagram. Now, there can be any antigen. Let me draw any antigen. The antigen can be bacteria, can be virus, can be fungus. Any foreign thing is the antigen. Imagine the antigen is present in the blood. This is antigen present in the blood. It can be bacteria, virus, fungus, parasite, some foreign substance. It can be anything, some toxin, some poison. Any foreign material is known as antigen. We know the definition of antigen, right? Now this is the antigen, right? Now there are 2 possibilities. Let me draw 2 antigen. Let me draw 2 antigen, right? Whenever antigen is formed, the body give immune response by humoral immunity by forming antibodies against the antigen. So this is the antigen. Now there are 2 possibilities. Kidney bhi 2 hai na? So let me draw one more. In both the kidney, I will show you one mechanism, right? In both the kidney, you can see the nephron. 1 nephron here, 1 nephron here. Now, the first possibility is that this antigen is going to the kidney directly, and antigen get deposited on the filtration barrier. Antigen get deposited on the filtration barrier. Now, this antigen was not initially present in the kidney. It is at this time it got deposited. So, such an antigen is known as planted antigen. It is known as planted antigen. Give me a thumbs up. This antigen is known as planted antigen. This antigen is known as planted antigen. You got my point? This is the thing, this is planted antigen. And sometimes so this is the antigen. So first antigen is coming, it is going to the kidney, getting planted on the filtration barrier. On what portion of filtration barrier, that depends on the type of glomerulonephritis. As I've told you, there are 10, 20, 30 type of glomerulonephritis. In various glomerulonephritis, the location of this antigen can be different in the triplet, whether in the basement membrane, whether in the endothelium, whether in the epithelium. So I will teach you individually when I will teach you the individual glomerulonephritis. So whatever is the location, it is in filtration barrier, that is triplet, right? Now body is forming antibodies against the antigen, वो पीछे पीछे आएंगी. The word to be picked here is पीछे पीछे. Antigen antibody complexes are not formed in the blood. First antigen is coming, it is going to the kidney, getting deposited in the barrier. Then antibody is also coming पीछे पीछे, behind. That is also going to the kidney. Antigen के पीछे पीछे जाएगी. And it will form antigen antibody complexes in the kidney. जहां जहां antigen deposit है, वहां antibody deposit होके complex बनेगा. When the complex is formed, the glomerulus will have inflammation. That is glomerulonephritis. So you tell me, antigen antibody complex कहां बना? Is it formed in the blood? No. Blood have individual antigen, individual antibody. But the complexes are formed in situ. This is known as in situ complex formation. Give me a thumbs up. This is known as in situ formation. So first antigen is coming. Imagine a bacteria is coming. The first antigen is coming. That is one of the bacteria is coming. That bacteria is going to the kidney, getting deposited in the nephron, in the glomerulus of the nephron, in the filtration barrier triplet of the nephron. One of the location of the three cells, either the center basement membrane or endothelium or epithelium. Now body is showing the immune response by forming antibodies. The antibodies are also going behind, पीछे पीछे, उसके पीछे पीछे जाएगी, जहां जहां एंटीजन गया उसके पीछे पीछे एंटीबॉडी जाएगी. So antibody will also get deposited on the same point where antigen is there. So antigen antibody complexes are formed that lead to inflammation and that lead to the disease known as glomerulonephritis. That is my chapter today. Give me a thumbs up. So my question is, where is the antigen antibody complexes are formed? I know individual antigen is present in blood, individual antibody is present in blood, but the complexes are formed in situ. That's why this is known as in situ antigen antibody complex formation. You got my point? This is in situ. This is in situ for which the antigen was planted. First, it was not initially present there. It is planted there. Now sometimes what happens, the antigen is not planted. The antigen is the integral part of the glomerulus. It is already present inside the glomerulus. It is present in me, you, every healthy human being. What is the filtration barrier? Can you tell me what is the filtration barrier? Let me draw one of the filtration barrier on side. Here I am drawing. It is basement membrane in the center, endothelium on one side. This is endothelium, and epithelium on other side. This is the epithelium, that is visceral epithelium on other side. I guess everyone knows this till now. Now I'm talking about this filtration barrier inside the kidney, right? I'm saying this time antigen is not planted. It is a part of basement membrane. You know basement membrane is made up of collagen, type 4 collagen. So antigen is type 4 collagen. Antigen is type 4 collagen and body is forming antibodies against that. You may ask me, ma'am, why body will form antibody against the own antigen? It is not a foreign. So in my kidney, I am having 1 million nephron. Inside each my kidney, inside each my nephron, I'm having this structure present inside me, right? So inside I'm having millions of basement membrane inside my each kidney, right? Now my body is not forming antibodies against the collagen of the basement membrane, but some individuals in which autoimmune diseases are there. But what do you mean by autoimmune diseases? In autoimmune diseases, body form antibody against the self antigen. Normally body form antibodies against the foreign antigen, but sometime in autoimmune diseases, immunity become deranged, immunity become mad, and immunity, that is antibodies are started forming against the self antigen. Here collagen is one of the self antigen. Collagen to sab mein hai na, it is present in everyone, but some of the individual will form antibodies against this. Now this antigen, this collagen is known as fixed antigen. It is already fixed in everyone's kidney. It is not planted like here. यहाँ पे बैक्टीरिया आया और बैक्टीरिया आके पहले प्लांट हुआ. यहाँ पे मैं कह रही हूँ पहले से ही प्रेजेंट है. Collagen is always present. So this one antigen is fixed antigen, and body started forming antibodies against that. So antibody will go, antibody will come, antibody will go and deposit on the collagen. So antibody will come, antibody will get deposited here. So again antigen antibody complexes are formed in situ. Again they are formed in situ, but against a fixed antigen. You got my point? Against a fixed antigen. And the third, these are the two, in situ planted, in situ fixed. ये हो गया. And the third is that What is the third scenario? The third and the last scenario in which antigen antibody formation complexes formed in the blood only, and after forming complexes they will go and deposit in the kidney. You got my point? So I'm summarizing. Those who are confused, for them, especially for them, those who are confused, still confused, I'm drawing the super 3 diagrams for you. No one will explain you pathogenesis of glomerular injury with such a simplicity. Today, after my lecture, I request all of you to read Robbins today only. So Robbins will become a cakewalk for you if you are watching my lecture with attentivity, and after that you are reading Robbins today only. Okay. So let me draw 3 human bodies. I'm drawing a rough diagram, so don't laugh. I'm drawing just to show you the pathogenesis here. I want to show you the pathogenesis, the 3 type of pathogenesis of antigen antibody complexes. I want to explain you what is in situ. In situ में भी 2 option है, planted or fixed antigen, or what is circulating. So what is circulating, what is in situ. So in each of them, I'm drawing kidney. Let me draw only one kidney. You know there are 2 kidney, but for the sake of understanding, I'm drawing only one kidney, right? Inside one kidney, okay. Let me draw the filtration barrier. So this is the basement membrane, endothelium, epithelium. I'm not drawing nephron. Nephron के अंदर की filtration barrier is important for me currently. I know inside the kidney nephrons are present, and inside the nephron, inside the glomerulus, this filtration barrier is present. But currently I'm drawing just filtration barrier to explain you. So this is basement membrane, this is endothelium, this is epithelium. This is basement membrane, this is endothelium, this is epithelium. I want to you understand that inside, पहले तो 2 kidney होता है. Humans have 2 kidney, not 1. For the sake of understanding, I am drawing only 1 inside each human. Number 1. After that, inside each kidney, 1 million nephron are present. But I am not drawing the entire nephron. Inside the nephron, there is glomerulus. And inside the glomerulus, there is filtration barrier. So I am interested in the filtration barrier of the glomerulus of the nephron. That's why I have drawn only filtration barrier. Everyone give me a thumbs up. Everyone, can you see the 3 diagrams? Yes, you all. Can you see the 3 filtration barriers? Yes, you all. Let me draw the blood vessel in each of them. One blood vessel will be required to explain you the meaning of the in situ and circulating, right? Let me take the first example. The first example is a bacteria. This is the antigen. The antigen here is a bacteria. The antigen, maybe any antigen can be there, bacteria, virus, parasite, fungus. It is the antigen. Basically, foreign antigen is there, right? This foreign antigen is there. So body will form antibodies. So let me draw this foreign antigen here also, the same foreign antigen here also. So this is the foreign antigen. This is a foreign antigen, right? So body will form antibodies against it. Now there are 2 possibilities. So these are the antibodies. So antigen antibody complexes are formed in circulation only. So let me draw this antigen and let me draw this antibody. These complexes are formed in the blood only. See, it is blood. Blood means circulation. And after forming, they are going to the kidney and getting deposited here. So what is this mechanism known as? You will say, ma'am, complexes are formed in circulation. The complexes are formed in circulation after forming antigen antibody complex. As the complex, they are going to the kidney and getting deposited. So this is the first mechanism. Antigen is coming. Antigen can be any. It can be bacteria, virus, fungus, parasite, any foreign material. So as soon as the antigen is coming in the blood, the body is forming antibodies against it. So antibody will bind with the antigen in the blood only. In the blood only, in the circulation only, and antigen antibody complexes are formed in the circulation. And after forming in the circulation, as blood goes everywhere in the body, this blood is going in the kidney also. So this blood is going via Apron Arteriole. It is entering the filtration barrier. It is entering the capillary. You understand? The capillary. And after that, it is getting deposited here. So it is destroying, it is causing inflammation of this portion, and it will lead to glomerulonephritis. So this mechanism is circulating antigen antibody complex formation. The antigen antibody complex are formed in the circulation. Circulation means blood. See the second possibility. The second possibility is that here antigen is there. Here also antigen is there. You can see like this. Here also antigen is there. But this antigen will go to the kidney, get deposited on the filtration barrier. Now you will ask, ma'am, where it will deposit? It will deposit in the basement membrane or on the endothelium or on the epithelium. So my answer is it varies from glomerulonephritis to glomerulonephritis. In different type of glomerulonephritis, this deposition will be different. The site of the filtration barrier में भी ट्रिपलेट है ना, तो ट्रिपलेट में कहाँ एग्जैक्ट लोकेशन बताओ, बेसमेंट मेम्ब्रेन में कि एंडोथेलियम में कि एपिथेलियम में, कहाँ, तो वो अलग अलग है. डिफरेंट टाइप ऑफ ग्लोमेरुलोनेफ्राइटिस हैव डिफरेंट टाइप ऑफ deposition, the location. So that I will discuss जब मैं individual glomerulonephritis discuss करूंगी. Here antigen is coming and getting deposited anywhere in the barrier, the triplet, anywhere. It can be anywhere. Now body will form antibody. Now body will form antibody, and antibody will come पीछे, behind. Antigen antibody complexes are not formed in circulation. The antigen antibody complexes are formed inside the kidney directly, inside the filtration barrier directly. Give me a thumbs up. So this is known as in situ. Antigen antibody complexes are formed. Here complexes are formed in situ. Here complexes were formed in the circulation. After as the assembly, antigen antibody assembly complex, they are coming in the filtration barrier and getting deposited there. Here first antigen is coming and piche antibody is coming, and the result is same. And result here also filtration barrier is destroyed, inflamed. Here also filtration barrier is destroyed, inflamed. Both of them are destroyed or inflamed by antigen antibody complexes. But here complexes were formed in the blood and then get deposited. Here first antigen is coming, then piche antibody is coming. So complexes are formed in situ. By in situ I mean the kidney itself. Give me a thumbs up. Everyone give me a thumbs up. So here in situ complexes are formed, right? In situ. Now what is the antigen here? Again come on the antigen. You will say, ma'am, antigen was not initially present. First it is coming in the blood, and from the blood first it is coming to the kidney and getting deposited in the filtration barrier. So such an antigen is known as planted antigen. We have planted the antigen first. वो पहले से नहीं था वहाँ. We have first planted it और उसके पीछे antibody को लाए. You got my point? Here antigen is not planted. It is present in blood only. In the blood only antibody is coming and forming the antigen. So see the complex. See the complex here. Here the antigen antibody complex. The word complex is formed in the blood, and as the assembly it is going to the filtration barrier in the kidney and getting destroyed. The glomerulus filtration barrier. Here first antigen is going और उसके पीछे antibody is going. Ultimately antigen antibody complexes, they are formed in situ. See this circle. This circle is in the circulation. This circle is inside the kidney. So that is the meaning of circulatory or in situ. Give me a thumbs up. Shall I come on the third possibility? Shall I come on the third possibility? This one is circulating complex formation. This one is in situ complex formation against a planted antigen. First we have plant antigen there. वहाँ पे पहले से antigen नहीं था. So first I brought a bacteria in the body. That bacteria is my antigen. The bacteria is going and getting planted in the kidney, getting fixed in the kidney. So planted there. Give me a thumbs up. Give me a thumbs up. Coming on the third possibility, who is the antigen here? Who is the antigen here? Here the antigen was bacteria, virus, fungus. Here also bacteria, virus, fungus, parasite, any foreign material. In the third possibility, the antigen is not a foreign. The antigen is self. The antigen is the collagen of the basement membrane. Collagen of basement membrane. Can you see? This is the basement membrane. The collagen of the basement membrane is acting as an antigen. You will ask me, ma'am, why the collagen will act as a basement membrane? The collagen of the basement membrane will act as antigen. Why? It is not a foreign, it is self, but the person is having autoimmune disease. There are few persons in which there is a disease that is autoimmune disease. In autoimmune disease, what is the problem? The body form antibodies against the self antigen, not the foreign. Self. Immunity become deranged. Immunity become mad. The plasma cells of the B lymphocyte become mad. They start forming antibodies against the self antigen. Who is the antigen here? Antigen is type 4 collagen of the glomerular basement membrane. So this antigen, this is an antigen, but this antigen is not planted. ये यहाँ पे पहले से था. It is not planted like this. Initially it is coming in the body, in the blood, and then going to the kidney. No, it is already present there. So this antigen is known as fixed antigen. What this antigen is known as? Now see the difference. This antigen is planted antigen and this antigen is fixed antigen. You give me a thumbs up. So it is never present in blood. Blood में तो है ही नहीं. These two antigens were first present in the blood and then going to the kidney. But this is not present in blood at all. It is already present in the kidney. So you tell me कहाँ पे बनेंगे complexes in this scenario? So body is forming antibodies in the blood and these antibodies are coming and forming antigen antibody complexes in the kidney. So here also in situ complexes are formed. यहाँ पे blood में बनने का तो chance ही नहीं है because antigen is not present in blood. Antigen directly present inside the kidney, right? So here also in situ complexes are formed. Now see, this is also in situ, this is also in situ, but this is against a fixed, against a planted antigen, and this one is against a fixed antigen. Now everyone appreciate my efforts. How many audience are watching me live? Give me thumbs up. Right now, give me thumbs up. If you got the three mechanisms. So ultimately, what are the three mechanisms? You tell me. You will say, ma'am, antigen antibody complexes, where they are forming. Based on that, we divide. So whether they are forming in blood or they are forming in kidney or they are forming in kidney. They are forming in blood, that is circulating antigen antibody complex formation. If they are forming in kidney, whether the antigen is planted or whether the antigen is fixed. Now once I will move this diagram, I cannot come on this again because it is a blank page. Once I will shift it now, ये फिर से नहीं आएगा. Have you got it? Shall I flip the page? I cannot show you this page again and I cannot draw it again, the same thing. If you have any doubt, I am giving you few seconds to ask that. Please write down in the chat box. I can see your chat. Anyone? Anyone? Sachin, Ashley, Arvind, Gaming, anyone? Do you have any doubt? Asmin, anyone? No? Shall I move ahead? I guess no one is having a doubt. So I am moving ahead. So this is the same thing written here. Now appreciate, you will be able to get it. So where the antigen antibody complexes are formed, whether they are formed in situ, that is inside the kidney, or whether they are formed directly in the blood. If they are forming in situ, there are two possibilities. Whether the antigen is fixed, that is collagen of the basement membrane, type 4 collagen, or whether the antigen is planted like a bacteria. Everyone gave me a thumbs up, right? You got it. I guess you got it. So same thing. This is the diagram from Robbins. Now I will show you, which I have simplified for you, forming 3 human beings, right? So this is the diagram. Robbins have not given 3 human beings. Robbins directly have given the filtration barrier. Now you can understand the 3 mechanism in the 3 filtration barrier. One by one, I will be explaining you the same. In this diagram, now let me zoom the first one. One by one we will be taking. मैं इसको zoom करती हूँ. Right, there are 3 possibilities in front of you. Let me zoom the first diagram. Only first diagram we will be discussing. Can you see this diagram? What you can see in this diagram? In this diagram, we can see this is the lumen of a capillary. This is the basement membrane. First appreciate this light pink color is the basement membrane, right? On the inner side of the membrane, this is endothelial cells. And on the outer side, these are the podocytes. Can you appreciate? This is visceral pore. So this is a filtration barrier. Now appreciate the lumen. Appreciate the lumen of the capillary. Can you appreciate the lumen of the capillary? In the lumen of the capillary, can you appreciate this thing? They are present already in blood, in the lumen of the capillary. Can you appreciate? So the red is the antigen, black is the antibody. So you can appreciate this is the antigen and this is antibody. So you can appreciate multiple antigen antibody complexes. They are already formed in the blood. In the lumen of the capillary, they are already formed. So this is the first scenario. Antigen is coming, antibody is formed, antigen antibody complexes, the assembly formed in the blood only. And after forming in the blood, they are coming and see, they are depositing. They are depositing in the filtration barrier. So this is circulating formation, circulating antigen antibody complexes formation. Give me a thumbs up. Can you appreciate? The antigen antibody complex formation takes place in the lumen of the blood. Now see the 3 diagrams together, you will have a better overview. See the 3 diagrams together. What I want to show you in the 3 diagram, देखो मैं specific बताऊंगी बहुत. Everyone look here. Can you see here the lumen? Appreciate the lumen of the capillary. Lumen, अंदर जो hollow lumen है ना वो देखो. In the lumen of the capillary, what is present here in the first diagram? What all these structures are there? In the lumen of the capillary, what is present here in this diagram? And in the lumen of the capillary, what is present here? You see the 3 diagrams and you yourself tell the answer. In the first diagram, I can see the complexes. I can see the complexes. So in the first diagram, antigen antibody complexes are already formed in the blood. In the lumen of the capillary means blood. So this is antigen antibody complexes formed in the circulation. Antigen antibody complexes formed in the circulation. After forming in the blood, they are coming and depositing there. Here, I can see multiple deposition. Can you see filtration barrier? They are depositing on the basement membrane also, on the epithelium also, endothelium also, everywhere they are depositing. But they are formed, already formed in the blood. Blood में बने बनाए हैं. But in the second and the third diagram, in the lumen of the blood, I can find only antibody. So the complexes are not formed in the blood. Only antibody is present here. Can you see? This is the antibody. This is the antibody, blank antibody. So where is the antigen? So can you see in this diagram, the antigen is the collagen of the basement membrane. Can you see these red dots? These red dots are present on the basement membrane. So the antigen here is the fixed. And can you see from the lumen, the antibody are coming here and getting deposited. So antigen antibody complexes are formed, but the complexes are formed in situ. They are formed in situ, inside the kidney only, and against a fixed antigen. See the third diagram. In the third diagram also, we have only antibodies there. Like the second, in the third also, we have lumen have only antibodies. So here also antigen antibody, this is the antigen. Now this antigen is a bacteria which is planted here. It was initially not present. But from the blood, first bacteria is coming, getting planted, or piche antibody is coming and getting deposited. So please appreciate antigen antibody complexes are formed. Everyone gave me a thumbs up, a big thumbs up. Yes or no? Have you got it? So these are the 3 diagrams. You can see I guess everyone got the three diagrams. Looking at the lumen of the capillary, you can decide whether the antigen antibody complexes are formed in the circulation or in situ. If the lumen of the capillary directly contain complexes, so they are formed in circulation. If the lumen of the capillary contain only antibody and the deposits are formed in situ, it is the in situ one. I guess everyone got it. Yes or no? Yes or no? So we are done. We are done with this thing. That is antibody mediated. Now I'm not giving the explanation of each of them. So let me skip this portion, right? Okay, just a second. Let me skip this portion. So I have already explained you. You can read the theory later on from the notes. You can ask me for the notes. I will send you the notes and you can read the theory directly from the notes. Now, coming on the second mechanism, that is cell mediated. Coming on the second mechanism, that is cell mediated. Just a second. We are done with the antigen antibody complex deposition. Coming on the second mechanism, that is cell mediated. In cell mediated, whatever is the antigen, the T lymphocytes, CD4 and CD8 T lymphocytes will come and they release cytokines. They release various type of cytokines that will cause destruction of the filtration barrier. That will cause inflammation in the cell filtration. Here antibodies are not formed. It is cell mediated immunity, not humoral immunity. Since antibodies are not formed, that's why cell mediated immunity is also known as POSI immune. POSI means less. POSI in pathology is less. Less immune means less antibodies. Here antibodies are not there. Since antibodies are not there, it is cell mediated immunity. The another name of cell mediated immunity is POSI immune. So this immunity is cell mediated. Here antibodies are not formed. Here CD4 and CD8 lymphocytes causes the destruction of the filtration barrier. CD4 and CD8 lymphocytes will cause the destruction of the barrier, and this immunity is known as POSI immune. Give me a thumbs up. The third pathway is the alternate pathway. In the alternate pathway, complement will come in the role. Complement will come in the role, right? Complement, especially C3. You know, in the blood C1 to C9 complement are present. That complement and properdin, these are the components of the complement system that will cause the inflammation of the barrier. That is filtration barrier, filtration membrane. So that is the three. Now coming on the location of the deposit. The next thing. Can you tell me the diagram of a glomerulus? Can you tell me the diagram? So in the diagram of the glomerulus, what I am drawing this one is the outer boundary, that is parietal. This one is parietal Bowman's capsule layer, parietal layer of the Bowman's capsule. Now let me draw multiple capillaries. Capillary number 1, capillary number 2, capillary number 3. I can draw multiple capillaries inside one glomerulus, right? All of them are lined. This is the red color is the basement membrane. Can you see? On the inner side, I will draw endothelial cells on each of them. On each of them, I will draw endothelial cells on the inner side. So this is the inner side appearance of red color is the basement membrane. See the color. Blue is the endothelium cell, and on the outer side, these are the visceral podocytes. These are the food processes of the visceral podocytes. So see the shape is like the foot of a human. These are the visceral. So I can draw the same in all. So that is the, you can appreciate the filtration barrier, the triplet. You can appreciate the triplet here. Everyone give me a thumbs up if you can appreciate this. Now, the space between multiple capillaries is filled by mesangial cells. So these are the filler cells. They are present everywhere. जो खाली बच गया, वहाँ पे mesangial supporting cells are there. So these cells are mesangial or supporting cells. Everyone give me a thumbs up. Have you got it? So this is the diagram of a normal glomerulus. Now, as I have told you, antigen antibody complexes are formed. So where the complexes are formed? What is the location? Currently I am telling you the 4 locations, 4 possible locations where the complexes, as I told you, various glomerulonephritis have various locations. So sometimes the deposits are present in the basement membrane. Can you see red color basement membrane? So these deposits are known as intramembranous. Such deposits are known as intramembranous deposit. That is deposits in the basement membrane. Sometimes the deposits are on the endothelium. Can you see? I'm drawing the deposits on the inner cell. This deposit, and I'm not drawing both. It can be antigen and antibody, both are there. So I cannot draw every time antigen and antibody. So these are the deposits. Imagine antigen as well as antibody. So such deposits are known as, they are on the endothelium now. That's why these are known as subendothelial. Subendothelial. So on the basement membrane, on the inner side of the basement membrane, now coming on the outer side of the basement membrane. They can be present on the epithelium. That is visceral epithelium. So such deposits are known as subepithelial deposits. So what are the 3 main locations? Basement membrane is intramembranous. subendothelium and subepithelium. And the last deposits can be present in the mesangium, mesangial cells. So the fourth location is the mesangium. So these are the four location of the deposits. But the term deposit, most of the student को समझता नहीं है पूरा चैप्टर पढ़ने के बाद कि मैडम ये डिपॉजिट क्या था, डिपॉजिट क्या था. डिपॉजिट इज द एंटीजन एंटीबॉडी कॉम्प्लेक्स. एंटीजन एंटीबॉडी कॉम्प्लेक्स बनाया ना हमने अभी. द एंटीजन एंटीबॉडी कॉम्प्लेक्स itself is known as deposit. Give me a thumbs up. That deposit is where? What is the location? So let me simplify this diagram. चलो इसी diagram को simplify करते हैं. Draw the basement membrane again. I will draw the basement membrane again with a simplicity like this. This is the basement membrane, right? We all know on one side of the basement membrane, we all have endothelium of the capillary. This is the endothelium of the capillary. On other side of the basement membrane, we have visceral podocytes or epithelium. So this one, the visceral podocyte and epithelium. And surrounding cells are the mesangial cells. So let me draw a few surrounding cells, that is mesangial cells around this triplet. So let me simplify it. Everyone give me a thumbs up. Have you got it? Have you got it? Now draw the location of the deposits. There can be four possibilities. What are the four possibilities? Who will tell me the four possibilities? The first possibility is the deposit are here, inside the basement membrane. ये कब बनेंगे? When the antigen is collagen itself, the fixed antigen. Autoimmune disease, that is Goodpasture syndrome, I will tell you. So this deposit is known as intramembranous. This location is known as intramembranous. Sometimes the deposits are on the endothelium. The deposits, multiple deposits are there on the endothelium. On the endothelium. So these deposits are known as subendothelial deposits. Sometimes the deposits are on the epithelium. You got my point. I guess you all got it, right? So this deposit is known as subepithelial deposit. And lastly, the deposits can be in the mesangial cells. These are known as mesangial deposit. I cannot simplify more than this. So these are the four locations of the deposits. What are the four locations of the deposit? Can you tell me? Inside the basement membrane, intramembranous, on the endothelium, subendothelial, on the visceral epithelium, podocytes, that is subepithelial, and on the mesangium. So these are the four locations of the deposit. Now anywhere can be the location. Ultimately barrier is disturbed. This is the barrier now. In the barrier there is a triplet along with the supporting cell. So anywhere is the deposit, the filtration barrier is disturbed. It is inflamed and the disease is glomerulonephritis. Have you got it? So these are the four different locations in front of you. It can be epimembranous or intramembranous, one and the same thing, where deposits are in the basement membrane. It can be subendothelial, it can be subepithelial, and it can be mesangial. Now whenever I will teach you individual type of glomerulonephritis, you will come to know. Now see the three diagrams. You tell me in diagram number 1, where are the deposit? Tell me the location of the deposit. Can anyone? Arvind, can you tell me? Gaming, can you tell me? Ashmin, Siddhika, Imlink, anyone who is watching me live. I can see only these names currently. So can you tell me the location of deposit in the first diagram, second diagram, third diagram? This diagram is from Robbins. We all know that. Can you tell me? In the first one, can you see this is the deposit? Antigen antibody complexes are deposited here. They are deposited here. So they are on the inner side of the basement membrane. So in this, I can see the deposits are subendothelial. Subendothelial. The deposits are subendothelial here, I can see. Give me a thumbs up because they are inner side of the basement membrane. You all can appreciate. In the second diagram, I can see the deposits on the membrane itself. On the basement membrane itself, I can see antigen antibody complexes are there. So in this diagram, the deposits are epimembranous or intramembranous. एक ही बात है. Epimembranous or intramembranous. On the contrary, in the third diagram, see the deposits are on the podocyte. Can you see? These are the podocytes. Can you see the deposits are on the podocyte, antigen antibody complexes. So these deposits are subepithelial. Subepithelial. I guess you all got it. I guess you all got it. Mesangial is not shown here, unfortunately. Mesangial यहाँ पे होंगे, the green color cells. The mesangial cells. Here can be the deposits, antigen antibody deposits. Everyone give me a thumbs up, right? So you can see now these are the same diagram from the Robbins showing all four deposits. Here in this diagram, the black color is the deposit. By deposit, I mean antigen as well as antibody complex. Now in the diagram, the complex is not shown. The black color deposits are containing both antigen also, antibody also, right? So here, okay, in the first diagram, you can see the first one. The labeling, there are four labeling, 1, 2, 3, 4. Can you see the 4? Now tell me the 4. What is 1, what is 2, what is 3, what is 4? See the location of all 4 them. The 4 type of deposits, the diagram from Robbins. Today only you will read Robbins and appreciate all these things in the Robbins only. Can you tell me what is 1? In the 1, I can see the deposit in the basement membrane only. This one, the pink one, is the basement membrane. And can you see the black deposits? They are present on the basement membrane. That's why this is epimembranous or intramembranous, one and the same thing. Epi or intra, ek hi baat hai, right? In the second one, this one, see the location of the deposit. The location of the deposit is on the podocyte, on the outer surface of the basement membrane, I guess. So this one is subepithelial. See, this is on the inner side, the third one. So this is subendothelial. And see the fourth one, they are present in the matrix, the supporting matrix, the green color supporting matrix. So these one are the mesangial. I guess everyone got it. Shall I move at the same diagram from Hirschman? The four type of deposits are there. In this diagram, the deposits are shown by pink color. In this diagram, the deposits were by black color. So whatever color coding you are using, your concept should be clear. So I guess we all got it. What are deposits? And what is the location of the deposit, right? You got my point. Now let me start glomerulonephritis. Let me classify glomerulonephritis. How many type of glomerulonephritis I am going to teach you today? Till now I have not even taught you single glomerulonephritis, and the lecture is already 1 hour, 1.5 hours, right? So in this we have seen the overview of the glomerulonephritis. We have seen the anatomy, histology of the normal kidney, normal nephron, normal filtration barrier, and we have seen the pathogenesis of the glomerulonephritis. Now let me come the classification of glomerulonephritis. We can classify glomerulonephritis into two categories, the primary glomerulonephritis and the secondary glomerulonephritis. So primary glomerulonephritis is predominantly involving the glomerulus only, the diseases in which mainly glomerulus is involved. Primarily glomerulus is involved, that is known as primary glomerulonephritis. And in the secondary, the person has some other disease, usko disease kuch aur hai, and the glomerulus is involved secondarily. That's why known as secondary. So there are nearly 9 primary glomerulonephritis which we have to study one by one. Sare ke sare padhne hain in detail. I will tell you all 9 in a comparative manner. And secondary there are many, but usually I teach 3 to 4 from this list, which are important. The diabetic one, the SLE one, the HS purpura, and some other. So यहाँ पे 3 या 4 ही पढ़ाऊंगी मैं. I will not teach you all secondary. The important one I will teach you. But primary we will complete all 9. And the third category you can see hereditary one. The hereditary one, glomerulonephritis, they are 4 in number. So I request all the students to make a comparative table between all. First make a comparative table between all 9. Then make a comparative table between these 3 to 4. Then make a comparative table between these 4. So this is the complete glomerulonephritis in number I am going to teach you. So let me come on the primary one. Can you see the primary? The 9 I am talking about. I'm sorry. These all are primary. Can you see these all are primary glomerulonephritis? So let me tell you the 9 names first. Uski baad we will make a comparative table between them and start studying them. The first is known as post-acute proliferative glomerulonephritis. Acute proliferative glomerulonephritis, also known as post-streptococcal glomerulonephritis, one and the same thing. So many students even don't know that these two terminologies are same. Now you have to learn the short forms, because in exam it is like PSGN only. So many students even don't know the full form of PSGN, APGN. You got my point? So what is APGN? What is PSGN? It is acute proliferative glomerulonephritis, post-streptococcal glomerulonephritis. You got my point? The second one is rapidly progressive glomerulonephritis. Rapidly progressive glomerulonephritis, right? The third one is minimal change disease, which occurs in children. The most common cause of nephrotic syndrome in children, I will teach you. So that is MCD. The fourth one is membranous, and the fifth one is membranoproliferative. The fourth is membranous glomerulonephritis, and fifth is membranoproliferative glomerulonephritis. So see the change. It is MGN, it is MPGN. It is only membranous. It is along with membranous proliferative also. So membranous glomerulonephritis, membranoproliferative glomerulonephritis. The next two, focal segmental, focal segmental. Now see, both are focal segmental. One is glomerulonephritis, one is glomerulosclerosis. Then this one is not glomerulonephritis. This one is glomerulonephritis. This one is known as focal segmental. This one is also known as focal segmental. But one is glomerulonephritis. One is glomerulosclerosis. What is the difference between all these? I will make a fun for you. The glomerulonephritis understanding will be super easy for you. If you are attending the lecture from the beginning, if you have attended the pathogenesis, it will be easy for you to understand all these. The microscopy, the gross appearance, the pathogenesis, everything I will teach you. Don't worry. So after these two, focal segmental, glomerulonephritis and glomerulosclerosis, the next one is IgA nephropathy. The next one is IgA nephropathy, the Berger's disease. And the last one is chronic. The last one is chronic. You got my point? So count, they are 9 in number. I am going to teach you all 9 one by one. These all are primary glomerulonephritis, right? Coming on primary की बात, secondary glomerulonephritis. In secondary glomerulonephritis, patient have some other disease. The patient have some other disease, but the glomerulus is involved secondarily, not mainly primarily. That's why these are known as secondary glomerulonephritis. Secondary glomerulonephritis. So here what are the diseases? SLE, diabetes, amyloidosis, PAN, polyarthritis nodosa, Wagner's granulomatosis, good pasture, HS purpura. They are many, but I will teach you SLE, I will teach you diabetes, maybe I will teach you amyloid kidney, maybe I will teach you HS purpura. So these 3-4 I am going to teach you in detail. I will teach you good pasture also. So these I will teach you in detail, not all, because the others are not really very important at your level. So that is secondary one. And the third one are the hereditary. In hereditary, the glomerulonephritis is congenital. It is present since childhood. So Alport disease is the most important here. The first is the Alport. Second is Fabry disease. The third is nail patella. And fourth you add here. It is thin membrane. There are 4 in number. Thin membrane disease or thin membrane glomerulonephritis. Give me a thumbs up. Everyone give me a thumbs up. So let me revise the classification of glomerulonephritis. Let me divide glomerulonephritis into 3 categories. The primary one, the secondary one, and the hereditary one. Can any one of you help me in enumerating the various names of glomerulonephritis first before going to the details of all of them? We will study the detail, each and every minute detail of all type of glomerulonephritis today only, right? So we will finish the topic end to end, cover to cover we will cover. So first enumerate them. The first step is to know their names. So in primary there are 9 in number. In hereditary there are 4 in number. In secondary there are many, but I will teach you only important one, right? Not all. So can you enumerate the 9 primary? The first one is APGN, acute proliferative glomerulonephritis, also known as post-streptococcal glomerulonephritis. The most important one, we will start from this one only. I will teach you all these in a comparative manner, in a super duper easy comparative manner. So it will be fun for you to study all 9 together, right? The second is rapidly progressive glomerulonephritis, RPGN. The third, also known as crescentric. Here crescents will be formed. Crescentric glomerulonephritis, this one only, right? The third one is MCD, minimal change disease. The fourth one and the fifth one I always teach together. So membranous glomerulonephritis and membranoproliferative glomerulonephritis. So in this only membrane is involved. Here along with membrane proliferation is also there. So membranous and membranoproliferative. So 1, 2, 3, 4th, 5th I always teach together. Then 6th, 7th also I teach together. So the next 2 are focal segmental. But one is glomerulonephritis, one is glomerulosclerosis. Don't worry, I will tell you the meaning of all these. Just I'm helping you to learn the names. पहले names तो देख लो. After that, I will teach you the detail of all these. Why it is glomerulosclerosis, why it is glomerulonephritis. I will teach you everything. Don't worry. Right? So after that, there is IgA nephropathy, the Buerger's disease, and the last one is chronic glomerulonephritis. Count, they are 9 in number. 1, 2, 3, 4, 5, 6, 7, 8, 9. So they are 9 in number. Everyone give me a thumbs up. Shall I move ahead? In the secondary, there are many. Important one are SLE, that is lupus glomerulonephritis, lupus kidney. The second is diabetes mellitus. I am teaching you HS purpura, good pasture syndrome. I will teach you all these, the important one. After that, coming on the hereditary, they are 4 in number. So very, very important. The most important is Alport disease. The first I will teach you Alport disease, the most important in hereditary. After that, it is, I guess, Fabry disease, then nail patella syndrome, and the last one is thin membrane disease. So these 4, all 4 I will teach you in detail. So these much we have to study today. All these glomerulonephritis we have to complete today only. Are you with me? Shall I start? So I will be teaching you all the glomerulonephritis after classification is over. Let me continue with glomerular disease, that is glomerulonephritis. Okay, I will teach you all these, the hereditary one, the secondary one, the primary one, but all the glomerulonephritis have same clinical feature. So I cannot teach you clinical feature individually when I will teach you individual glomerulonephritis. So before starting the individual glomerulonephritis, let me teach you the manifestations of glomerulonephritis in one shot only. सबका एक ही साथ बता देती हूँ clinical manifestation. So before starting the individual, let me teach you the presentation, the clinical feature, the manifestation, जो भी बोलो, either presentation of the glomerulonephritis, clinical features of glomerulonephritis, or the clinical features or manifestation of glomerulonephritis. All glomerulonephritis either end in nephritic syndrome or nephrotic syndrome. Either they result in nephritic or nephrotic. Now, most of the students even don't understand what is the meaning of nephritic, nephrotic. What is the difference in nephritic, nephrotic? Nephritic and nephrotic syndrome is not a disease. It is a syndrome. You know, it is a word which includes multiple glomerulonephritis which all have same clinical features. It is also a word which have multiple glomerulonephritis which all have same features. So first understand the clinical features में क्या difference है. So there can be two type of patients in front of you. Right, there is a patient which is having a group of symptoms. You can label it, these are nephritic symptoms. There is symptoms अलग-अलग हैं. Nephritic symptom में patient के urine में blood मिलेगा, blood in the urine. यहाँ पे blood नहीं मिलेगा urine में, never you will find. So patient will come to you, my urine is red, means the patient is having nephritic syndrome, not nephrotic. तो आधे glomerulonephritis तो यूं ही हट गए. So you are having only few in the options. Now उनमें से क्या है, do the biopsy and come on the confirmation. You got my point. So it narrow your diagnosis once you study the clinical features which come under nephritic and nephrotic syndrome. Have you got it? What is nephritic, nephrotic? I will teach you both one by one. After that, I will start individual glomerulonephritis. Yes. So let me start with nephritic syndrome. In nephritic syndrome, there are 5 clinical features. In nephrotic, there are 6. So in the nephritic, these are the 5 clinical features patient will come to you. Now, after getting your certificates, you will practice as a practicing doctor. You will be a licensed doctor. So whenever any patient come to you with these 5 clinical features, the patient is having nephritic syndrome and you should know all the causes of nephritic syndrome. So patient is having one of them. Patient is having any one of them, right? So the first important feature is hematuria. Hema means blood. Urea means urine, blood in urine. So patient complains of blood in urine, either gross or microscopic. Sometimes it is gross, so the urine is gross red in color, but it is rare. Mostly it is microscopic. So patient cannot find the urine is red. But if you do the lab analysis, the urine analysis in the lab, in the microscope, RBCs are seen in the urine, but they are not that much that they give red color to the urine. Sometimes they give, sometimes they don't give, depending on the concentration of RBCs in the urine. So hematuria is the first feature, which differentiate nephritic from nephrotic. The most contrasting feature between nephritic and nephrotic is the hematuria, which differentiates the two. Hematuria present in nephritic syndrome. It is absent in nephrotic. Please be crystal clear in your concept, right? The second thing, patient also have protein in the urine, proteinuria, but it is very mild. Now this proteinuria present in both, nephritic also, nephrotic also. But if it is mild, it is nephrotic. If it is severe, it is nephrotic. So proteinuria present in both. So protein in urine, the second thing. If you measure the blood pressure of the patient is hypertensive. The patient is having blood pressure more than 120/80. You know the normal systolic and diastolic blood pressure is 120 and 80. It is here more than 120/80, right? The patient will complain of edema, especially below the eyes, especially in the morning. The patient have edema. In layman language, edema is swelling. So the patient will say, you doctor, I'm having swelling in the body. Where? Especially on the soft tissue, in the ankles, in the just below the eye, that is periorbital edema. They are very typical. And in the morning, once the patient get up, the face is puffy. The face is having edema. The eyes, below the eyes, there is edema. So that is swelling. And last is oliguria in the end stage, not at the initial stage, oliguria. What is the definition of oliguria and anuria? Oliguria is urine output in 24 hours, less than 400 ml. In complete 24 hours, the urine output of the patient is less than 400 ml. The patient is having oliguria. And if it is less than 50 ml per 24 hours, it is known as anuria. So patient is going in renal failure. The patient is going in acute or chronic renal failure. So these are the 5 features. What are the 5 features? It is blood in urine, protein in urine. First learn the 2. Blood in urine, hematuria. Protein in urine, proteinuria. Hematuria to hai, but proteinuria is mild. It is not severe. It is mild. After that, hypertension, edema, and oliguria. These are the 5 features of nephritic syndrome. Okay. Hematuria, because of the blood in urine. It is blood in urine. The urine is smoky in color. This urine is red in color. Sometimes you will find RBC cast on microscope in the urine. Proteinuria is mild. Can you define mild and severe? कितना प्रोटीन यूरिन में होगा तो you will say ma'am proteinuria is mild, and कितना होगा तो severe. There should be some cutoff, right? The cutoff is 3 gram per 24-hour urine. So there is a patient in front of you, right? The patient is having edema, oliguria. You are suspecting some glomerulonephritis in the patient. Ask the patient to do a 24-hour urine analysis. What is 24-hour urine analysis? Start the test 8 a.m. in the morning, right? from today until tomorrow 8 a.m. in the morning. So for 24 hours, ask the patient, don't void the urine in the commode in the toilet. Collect all urine in a jar, in a bucket, in a sterile bucket. So collect all the urine in a jar and submit it to the laboratory after 24 hours. So in the lab, they will see how much is the volume, how much is the protein. If 24-hour urine contain protein less than 3 gram, this is less than 3 gram protein in 24-hour urine. So it is mild proteinuria. And if it is more than 3 gram of protein per 24-hour urine collection, it is severe. So mild is seen in nephritic syndrome and severe proteinuria is seen in nephrotic syndrome. Proteinuria, that is protein in urine, it is seen in nephritic as well as nephrotic. Does normal person urine have protein in the urine? A very mild amount. How much? I'm saying it is 3 gram, matlab 3000 milligram. Normal urine, normal healthy urine have less than 150 milligram of protein in the urine. It is nearly nil. It is nearly na ke barabar hai. 100 to 150 milligram may be present in urine in a normal healthy individual. But if it is 150 to 3000, it is nephritic syndrome. If it is more than 3000 milligram, it is nephrotic syndrome. So that is the thing. So that is proteinuria. And proteinuria here is non-selective. Non-selective means all the protein will come in the urine. It can be albumin, globulin, transferrin, multiple protein will come in the urine. In contrast to nephrotic syndrome, where proteinuria is selective and only albumin come in the urine, not other protein. So proteinuria occurs in both nephritic, nephrotic. But there are two differences. In nephritic, proteinuria is mild, that is less than 3 gram per 24 hour. In nephrotic syndrome, proteinuria is severe, that is more than 3 gram per 24 hour. In nephritic syndrome, the proteinuria is non-selective, that is all protein excreted in urine. In nephrotic syndrome, the proteinuria is selective, that is only albumin is excreted in urine. Give me a thumbs up. So these are the two differences. Coming on hypertension, hypertension is there, but it is only a feature of nephritic, not nephrotic. Edema again occurs in both. Again here edema is mild and wahan pe edema will be severe, right? And oliguria is a feature. You know the definition of oliguria. Less than 400 ml of urine per 24 hours. Again, ask the person to collect the urine for 24 hours in a jar, in a bucket, and see the volume, how much urine is excreted in 24 hours. Normal human beings ke liye urine excretion is 1 to 1.5 liter. Normal excretion or more than that, right? But less than 400 ml is defined as oliguria. So now tell me the examples of nephritic syndrome. So what we have learned, what are the 5 features of the nephritic syndrome? First, tell me the 5 features of the nephritic syndrome. I am asking nephritic, not nephrotic. C-I, nephritic. Tell me the 5 features. Who will tell me the 5 features? It's hematuria, that is blood in urine, right? Hematuria. It's proteinuria, that is protein in urine. Hematuria, proteinuria. The third is hypertension, rise in blood pressure. The fourth is edema, that is swelling, and the last is oliguria, that is urine output less than 400 ml per 24 hours. If these 5 features are present in any patient, the patient is having nephritic syndrome. Now give me the examples of nephritic syndrome. Which glomerulonephritis present as nephritic syndrome? Which of them? So which glomerulonephritis present as nephritic syndrome? From the primary, I have told you 9 primary now. From the primary, it is the first one, PSGN, it is nephritic syndrome, right? The second one, RPGN, it is also nephritic syndrome. But the third, MCD, it is not nephritic. The fourth, membranous, it is not nephritic. Ye dono nephrotic mein bataungi. The fifth, membranoproliferative, again it is nephritic. Focal segmental glomerulonephritis, FSGN is nephritic, lekin FSGS will be nephrotic, right? So you have to learn the name. And IgA nephropathy is nephritic. So out of 9, 5 are nephritic. Learn the name of 5. Learn these 5. Out of 9, these 5 are nephritic. The remaining will be nephrotic. So you have to learn ki kaun sa glomerulonephritis will present with what clinical features. Now when I will teach you all 9 one by one, as I have told you, I am going to teach you all 9. All these 9 one by one. So when I will teach you PSGN, RPGN one by one, I will not tell you clinical features. I will say कि PSGN में nephritic syndrome होता है. So you understand कि nephritic है तो patient will present with 5 clinical features. You already know what are the 5 clinical features. When I will teach you RPGN, मैं सिर्फ एक लाइन बोलूंगी कि पेशेंट को नेफ्राइटिक सिंड्रोम होगा. यू विल अंडरस्टैंड कि नेफ्राइटिक का मतलब क्या होगा. ईच टाइम आई विल नॉट गिव यू द एक्सप्लेनेशन ऑफ नेफ्राइटिक सिंड्रोम. सो इन कॉमन मैंने शुरू करने से पहले ही आपको समझा दिया व्हाट इज नेफ्राइटिक. यू गॉट माय पॉइंट. सो दीज 5 glomerulonephritis present with nephritic syndrome. If you want to learn all, it's good. If you can't learn all 5, learn RPGN. It is the most common cause of nephritic syndrome. It is the MCQ. The most common cause of nephritic syndrome is RPGN among these 5. ये बहुत बार repeat MCQ है. Most common cause of nephritic syndrome is RPGN, rapidly progressive glomerulonephritis, also known as Cricentric glomerulonephritis. Coming on nephrotic syndrome. I am done with nephritic. Coming on nephrotic syndrome. In nephrotic syndrome, 6 features are present in the patient, not 5. The first thing, hematuria is absent here. यहाँ पे hematuria नहीं है. Directly start with proteinuria. Directly start with proteinuria, but this time proteinuria is massive. It is severe. Yes, Asmin. It is severe. It is massive. So what is the definition of severe or massive? Asmin, Malik, what is it? It is more than 3 gram per 24 hour. Yes or no? Yes or no? Because all maximum protein is excreted in urine. Maximum of the protein is excreted in urine. And which protein? It is selective. It is not non-selective like nephritic. It is selective. Albumin is excreted in urine. So maximum जो प्रोटीन जा रहा है वो एल्ब्यूमिन है. So blood में एल्ब्यूमिन will be low because it is excreted in urine ना. तो blood में it will be low. So it is hypoalbuminemia. So both things are related. If the patient have massive proteinuria, then only the person can have hypoalbuminemia. You may ask me a question कि why you have not told hypoalbuminemia and nephritic syndrome. वहां भी तो proteinuria हो रहा था ना. You should ask me a question. There are 2 answers for this. Number 1, वहां पे proteinuria was mild. थोड़ा सा protein excreted in urine, not much. But here proteinuria is massive. Here maximum protein is excreted in urine. That's why blood में low है. That's why. वहां पे mild was excreted in urine, तो blood में कुछ खास फर्क नहीं पड़ा. That is the first reason. The second reason, वहां पे proteinuria and nephritic syndrome, it was non-selective. All the proteins, it was mild and all the proteins were excreted in urine. Not only albumin. Here it is selective. Here only albumin is excreted and even severe. It is massive. That's why blood में albumin concentration falls drastically. Right? That is hypoalbuminemia. Give me a thumbs up. And that leads to edema. अब edema वहां भी था, edema यहाँ भी है. Right? Edema there was mild and edema here is severe. Here edema is severe. The cause of the edema in the 2 is different. Although edema is there, now patient के लिए तो swelling है. Patient आके बोलेगा डॉक्टर साहब सूजन आ गई है. Sujan is swelling, right? Now it can be nephritic, it can be nephrotic. The reason is different. If the edema is mild, it is due to nephritic. वहां पे reason I forgot to tell you, it is sodium and water retention in the body. Since the kidneys are not functioning, patient was having oliguria there if you remember. वहां पे oliguria का मतलब क्या होता है? What do you mean by oliguria? Oliguria is a feature of nephritic syndrome, which I have already taught you, right? Oliguria means less urine. Less urine. What does urine contain? Urine contains sodium and water. Patient is not excreting sodium and water now because patient is in oliguria. So sodium and water is retained by the body. Oliguria means sodium and water is retained by the body. And this sodium water retention leads to edema. So that is the cause of edema in nephritic syndrome. But in nephrotic syndrome, the cause of edema is decreased oncotic pressure. You know what is osmotic or oncotic pressure? The pressure due to the protein. Here protein in the blood become less. Albumin in the blood become less. So oncotic pressure will reduce and that can lead to edema. You got my point? The next patient have hyperlipidemia. The lipid in the blood will increase. You should ask me a reason. Pathology is all about why and how. What, why, how? इन सब के आंसर्स के लिए हम पैथोलॉजी पढ़ रहे हैं. So you should ask me the reason for all these. Why the patient have increased lipid concentration in the blood? Why? Why at all the patient must have increased lipid in the blood? I will tell you the reason. Increase lipid not only blood in urine also. So patient have hyperlipidemia, hyperlipiduria. So increase lipid in the blood, increase lipid in the urine, and the blood become hypercoagulable. I will be describing all these one by one. Let me start with the first one, massive proteinuria. As I have told you, the proteinuria is massive here. The proteinuria is severe. The definition of severe or massive is more than 3 gram per 24 hour. The protein excretion is more than 3 gram per 24 hour. And protein loss is selective. That is only albumin is excreted in urine, not others. Right? So that is the thing. That's why most of the albumin is lost in urine. Loss of most of the albumin in urine. That's why it leads to hypoalbuminemia. Less albumin in the blood. ईमिया का मतलब होता है ब्लड और यूरिया का मतलब होता है यूरिन। तो यहाँ पे ब्लड में लेस एल्ब्यूमिन है, दैट रिवर्स एजी रेशियो, यू नो एजी रेशियो, एल्ब्यूमिन ग्लोबुलिन रेशियो, एल्ब्यूमिन इज द न्यूमरेटर, ग्लोबुलिन इज द डिनोमिनेटर, सो यू आर सेइंग न्यूमरेटर इज रिड्यूस्ड, सो द रेशियो विल रिड्यूस्ड, एजी रेशियो रिवर्सल हो जाएगा। यू गॉट माय पॉइंट? You got my point? Now, along with albumin, some other proteins are lost, but in minor concentration. Mainly, albumin is lost in urine. But what other proteins apart from albumin are lost? Can you list it? Can you tell me the name of other proteins which are lost in urine? Can you list it? The most important is immunoglobulin. Immunoglobulins are antibodies. There are 5 types of immunoglobulins in blood. Gamma, IgG, IgA, IgM, IgD, IgE. There are 5 types of immunoglobulins present. They will reduce. What is the function of immunoglobulin? They give immunity, humoral immunity. If immunoglobulin is reduced because they are lost in urine, right, the person is susceptible to infection. So that's why a person with nephrotic syndrome is more susceptible to infection. This is the reason. Now you can correlate. मैं बोलूंगी कि nephrotic syndrome है, patient को glomerulonephritis है, उसमें infection ज्यादा है, तो बोलूंगी link क्या है मैम? Why the patient with nephrotic syndrome or patient with glomerulonephritis can have more infection, more vulnerable to infection? Why? What is the connection? The connection is this: because in nephrotic syndrome the patient have severe proteinuria, so most of the protein is lost in urine. One of the protein is immunoglobulin, so patient may immunoglobulin are lost in the urine, so less immunoglobulin in the blood, so less immunity in the blood, so increased chances of infection. So name the infection which is most common in such patients. These patients have spontaneous bacterial peritonitis very commonly. This infection occurs very common because they are vulnerable to the infection. So bacterial infections are common. Or kaun sa bacterial infection? So the patient with a nephrotic syndrome have high chances of developing bacterial peritonitis. They have high chances of developing bacterial peritonitis. Name the most common bacteria. The answer is pneumococci. Pneumococci followed by E. coli. So pneumococci and E. coli infections are very common in nephrotic syndrome. So these all things you will get in your clinical scenario question. A 45-year-old male patient having one of the glomerulonephritis, having severe proteinuria, having this, that, he is vulnerable to some infection. He is having spontaneous bacterial peritonitis. So the clinical scenario is about the nephrotic syndrome and which is leading to the infection in the patient. Most common bacteria is pneumococcus followed by E. coli. Other proteins which are lost is antithrombin. You know, blood mein antithrombin is present. It is lost. It is lost in urine. And what is the function of antithrombin? Antithrombin prevents coagulation in the blood. In my blood, I am having antithrombin in me. I don't have nephrotic syndrome. I am having antithrombin in me. So my blood is not coagulable. So without injury, there is no clot formation. Inside me, thrombus is not formed. You know, thrombus formation ki 3 reasons I taught you in general pathology. The Virchow triad. If you have remembered, if you have understood the Virchow triad, the general pathology, the reason for thrombus formation. So there are 3 reasons. The third reason is hypercoagulability, that is loss of antithrombin 3. Now this is the reason why a person with nephrotic syndrome have multiple thrombus formation, renal vein thrombus formation. So it is very common to find thrombus in a person with nephrotic syndrome. You will say, ma'am, what is the connection? Nephrotic syndrome hai kidney mein. You are saying thrombus are formed in the blood. Connection kya hai? This is the connection. Because in nephrotic syndrome, patient have severe massive proteinuria. So most of the protein are lost in urine. So antithrombin is also a protein which is lost in urine. So blood concentration of antithrombin will fall. That can make the blood hypercoagulability. That will give the blood hypercoagulability. You got my point? You got my point? The next protein which is lost in urine is transferrin. That's why the patient will be anemic. Transferrin is required. Transferrin is the transporter of iron. If you know, transferrin is the transporter of iron. If transferrin is less, iron absorption will be less. Iron is less, patients have iron deficiency anemia, which is a microcytic hypochromic anemia. So this is the reason why a patient with nephrotic syndrome presents with anemia. You can ask me a question कि मैम anemia क्यों होगा? Patient को तो kidney का problem है ना? Patient have some problem in the kidney. Patient is having one of the glomerulonephritis, which leads to nephrotic syndrome. Why the patient can have iron deficiency anemia? What is the connection? The connection is this: because patient is losing most of the proteins in urine, and transferrin is one of the protein. So transferrin is lost in urine. So less transferrin in blood. Transferrin is required for iron absorption. So less iron in the blood. Iron less, it will lead to iron deficiency anemia, which is a microcytic hypochromic anemia. So make a flowchart for all these, right? You got my point. Next protein which is lost in urine is called cholecalciferol binding protein. That will lead to hypocalcemia. If you see the calcium concentration in blood, it is less in such persons, and this is the reason. This patient have also thyroxine binding globulin lost in urine. That's why these patients usually have hypothyroidism. So nephrotic syndrome patient can come to you as a complication, and the patient can have hypothyroidism. So this is the connection. This is the connection, right? Ceruloplasmin is also low, that is copper level will be low. All the proteins are reduced in blood because they are lost in urine. Only one protein increase in blood in nephrotic syndrome, and the name of that protein is fibrinogen. Fibrinogen level increases in nephrotic syndrome. So I am teaching you right now nephrotic syndrome. Nephrotic syndrome. Nephrotic syndrome have 6 features. The first feature is proteinuria, which is massive or severe proteinuria. Proteinuria, in which most of the protein is lost in urine. So in the blood, less protein is there. In the blood, less protein is there. So mostly albumin is lost. So patient have hypoalbuminemia. Albumin is reduced in the blood. That reduces, because of which the patient have less osmotic pressure and patient have edema. These are the consequences. Not only this, patient have reduced immunoglobulin, which leads to infection. Not only this, patient have reduced thyroxine, so because of which patient have hypothyroidism. Not only this, patient have hypothyroidism, I am unable to write. Patient have reduced transferrin, because of which patient have anemia. Or कौन से थे, I just forgot. So patient have what other proteins were there? Patient have reduced antithrombin, because of which patient have more chances of thrombus formation. So all these proteins are lost in the urine. That's why their concentration is reduced. Only one protein in the blood increases in nephrotic syndrome. The answer of that is fibrinogen. Fibrinogen increases in blood, not decreases. So the combination of the two, fibrinogen is fibrinogen is a thrombolytic protein. So decrease antithrombin and increase fibrinogen both leads the blood as hypercoagulable. So hypercoagulability of the blood is due to these 2 reasons. So that is the nephrotic syndrome protein. Edema is there. Edema is severe and it is due to fall in osmotic pressure, not due to sodium water retention like nephritic syndrome. The next is hyperlipidemia. Now, why the lipid increases in blood and in urine in patient with nephrotic syndrome? What is the reason? Okay, so you tell me from where protein comes in blood. You tell me from where protein comes in the blood. Let me draw a blood vessel. Okay, this is a blood vessel. Inside the blood vessel, can you tell me the source of the protein? From where protein come? This is the protein present in our blood. This is a normal healthy human. Healthy human के blood में protein कहाँ से आता है? There are 2 sources. You should tell me, ma'am, dietary protein which we eat in the diet. We eat egg, we eat pulses, we eat soya bean and meat. So these are the sources of protein. So whatever protein we take in diet, so that get absorbed from the intestine and come in blood. So that is the first source, the dietary, the intestinal, right? The second source of protein is liver. Liver also synthesizes protein, right? The second source of protein is liver. Here you can see the liver synthesize protein and give in the blood. So see the 2 sources of protein in the blood. This is normal. We all know that. Why I'm telling you this? Let me give you a minute. So now let me draw a kidney. Normally, when this blood is going to the kidney do not excrete protein. In a normal healthy human, kidney do not excrete protein. But if the kidney has nephritic or especially nephrotic syndrome, there is massive proteinuria. So all this, currently I am talking about nephrotic syndrome. So just suppose this kidney is not healthy kidney. This kidney is having nephrotic syndrome. So whatever protein going in the kidney, that is excreted in urine. So the blood concentration of the protein falls, dramatically falls. Because the proteinuria here is massive. Massive proteinuria is there. Most of the protein is lost in urine. So blood में protein concentration is false. So liver will try to compensate. This loss by trying to increase synthesis of protein. Now lipoprotein are one of the proteins. Yes or no? What are lipoproteins? Lipoprotein is VLDL, LDL, all these. So liver will try to compensate the loss of the protein which is occurring in urine and nephrotic syndrome by causing increased synthesis of lipoprotein. So basically liver is increasing the synthesis of lipoprotein. Because there are more lipoprotein in the blood, lipid absorption will increase. So patient have more lipid in the blood. That's why this patient have hyperlipidemia. That's why patients with nephrotic syndrome have hyperlipidemia. This is the reason, because liver is trying to compensate the loss of the protein by causing increased synthesis of one of the protein, lipoprotein. So lipoprotein is increased. That's why patients have hyperlipidemia, and the increased lipid will go in the kidney also and excreted in the urine also, and that's why patients have lipiduria, hyperlipiduria. So lipid increases in the blood first and then increases in the urine. So lipidemia and lipiduria both are features of nephrotic syndrome. So blood, increased blood levels of total lipid, cholesterol, triglyceride, VLDL, DL, because liver is trying to compensate. Liver is responding to heavy proteinuria and trying to compensate by increasing synthesis of lipoprotein. So that is the reason. And increased lipidemia followed by lipiduria. Increased concentration of lipid in the blood, excreted in the urine. So that is the thing. And the last is hypercoagulability. I already taught you the reason for hypercoagulability, that is loss of antithrombin and increased fibrinogen. These both will contribute to hypercoagulability. Now give me the examples of nephrotic syndrome. So in nephrotic syndrome, it is MCD. MCD is the most common example. Membranous glomerulonephritis, membranoproliferative presents with both. ये वहां पे भी था, यहाँ पे भी है. Focal segmental glomerulosclerosis. It is nephrotic syndrome, and again IgA present with both, right? If you want to learn all, it's good. If you don't want to learn all, learn the most common. Most common cause of nephrotic syndrome. In children, it is minimal change disease. In children, it is minimal change disease, and in adults, it is membranous glomerulonephritis. So the answer is different in children and in adult. Let me give you the final summary, full and final summary of nephritic and nephrotic. I am done. I am done with nephritic and nephrotic, and now I will teach you individual glomerulonephritis, right? So nephritic, please revise with me. Help me in revising. Nephritic, nephrotic. Please everyone see, here it is I, here it is O. Nephritic and nephrotic. First, tell me the 1, 2, 3, 4, 5 symptoms here, and 1, 2, 3, 4, 5, 6 symptoms here. Who will help me? Nimisha, Malik, anyone else? Fernando, anyone would try to help me? The 5 symptoms of nephritis. Then we will come on the examples and most common. The second thing. First, tell me the 5 features. So let me start with nephritic. The most important feature is hematuria. Hematuria, that is blood in urine. Hematuria is absent here. Hematuria is never seen here. Yes or no? The second feature here is proteinuria. Proteinuria, but this proteinuria is mild. Here also the first feature I will write is proteinuria, but this proteinuria is massive. You know the specific cutoff, it is 3 gram per 24-hour urine. Less than 3 gram per 24-hour urine, mild proteinuria. More than 3 gram per 24-hour urine, it is massive proteinuria. So it is 3. If I say 2.9, it will go towards nephritic syndrome. If I say 3.1, it will go towards nephrotic syndrome. So the cutoff is the 3 that you have to take in consideration. Give me a thumbs up. So that is the proteinuria. The next feature is the edema. Edema. Again, yeah, non-selective, selective also. Malik, very good. So this side, the proteinuria is non-selective. That is, all proteins are excreted. And this time, this side, more or less, it is selective. Especially albumin is excreted. Edema, again, here it is mild. And edema, again, here it is massive or severe or massive, right? The cause of edema is different in both of them. Who will tell me the cause of edema? The cause of edema here is sodium and water retention. Sodium, water retention. The cause of edema here is decreased osmotic pressure. So please learn the cause of edema is different in nephritic and nephrotic syndrome. इसपे बहुत question आता है, right? The next two here is hypertension and oliguria. These are the features of nephritic only. These two are not common in nephrotic. Hypertension is mild. Oliguria का definition है less than 400 ml of urine per 24 hours. That is based on the volume of urine. Coming here, most of the protein is lost in urine. Massive proteinuria leads to hypoalbuminemia. So less albumin in the blood. We understood that also. There is hyperlipidemia in the blood and hyperlipiduria in the urine. Hyperlipidemia, that is increased lipid in the blood, and hyperlipiduria, that is increased lipid in the urine. You know the reason for both of them, I guess. And last one, the blood become hypercoagulable. Hypercoagulable. Everyone give me a thumbs up. Everyone. Abdullah, there is no hypertension in nephrotic. Hypertension is a feature of nephritic, not nephrotic. You got my point, Abdullah? Yes. So these are the 5 and 6 features of nephritic and nephrotic syndrome, crystal clear in front of you. I guess isme no student, none of the medical students should have even a slightest doubt here. You shouldn't have any doubt here. After that, I would like to move on the examples. Okay, I'm not writing all the examples. Tell me the most common cause of nephritic syndrome and tell me the most common cause of nephrotic syndrome. Who will tell me? In nephritic syndrome, answer is very simple. Only one answer is there, RPGN, rapidly progressive glomerulonephritis. Rapidly progressive glomerulonephritis, the most common cause of nephritic syndrome in children also, in adult also. But here the answers will be different. Here the answer will be different for children and here the answer will be different for adult. Who will tell me the two answers? In children and adult, who will tell me the two answers? If I ask in children, the answer become minimal change disease, that is MCD. And if I ask in adult, the answer will become membranous glomerulonephritis, MGN. Everyone give me a thumbs up. This is the summary. Can you see the board? I guess you can see, right? So this is the summary of, can I flip? Can I move ahead? This page will not come again. So that is the summary of nephritic and nephrotic syndrome, right? We have done the nephritic and nephrotic syndrome. The same thing is written in front of you. You can read the thing, what it is written. You can see the most common cause of nephritic syndrome, nephrotic syndrome in adults, it is membranous glomerulonephritis. And if you ask about the children, it's minimal change disease. So in children and in adults, the answer is different. Everyone give me a thumbs up. Shall I move ahead? Shall I move ahead? The reason for edema is different. The reason for edema in nephrotic syndrome is hypoalbuminemia. And the reason for edema in nephritic syndrome is sodium water retention. I have already explained you the two things. I guess we are done with nephritic and nephrotic. Does anyone have any doubt? You can read all the points. I have already explained you all the points, which feature is common where. So we will see all the points one by one. See the proteinuria. This is nephritic and this is nephrotic. Proteinuria is mild here and proteinuria is heavy here. The cutoff is 3 gram per 24 hour and non-selective, selective is also a part. Hypoalbuminemia is present here because most of the protein is lost, but not here. So it is absent here. Edema, again both the things. Here it is mild and here it is marked. The reason for the edema, here it is sodium water retention and here it is decreased osmotic pressure. The reason for the edema, right? Hematuria, hypertension and oliguria. These three things are present here. Hematuria, hypertension and oliguria. These three things are absent here. Absent, absent and absent, right? Now the remaining three things, you can see the remaining three things, that is hyperlipidemia, hyperlipiduria and hypercoagulability. These three things are present here but absent here. You already know this. I guess I have already crystal clear concept I have given to you. Everyone give me a thumbs up. Shall I move ahead? So these are the differences between nephritic and nephrotic. I would like to ask few questions based on nephritic and nephrotic. If your concepts are clear, you please answer it and please write your answer in the chat box. I want to see who is the first and who is the correct, right? I want more things, accuracy and speed, right? So please don't rush. Read it, give it a thought and then tell me what is the correct answer. So hypercoagulation in nephrotic syndrome is due to which reason? We know in nephrotic syndrome, the blood becomes hypercoagulable. Tell me the reason for that. I taught you two reasons. One of them is given in the option. The 4 options are in front of you. So what is the correct answer? Abdullah, Siddiqa, Saima, Malik. What is the answer? Who will tell me? What is the correct answer here? So is it loss of antithrombin? Is it decreased fibrinogen? Is it decreased metabolism of vitamin K? Or is it increased protein C? What is the reason? So yes, Yadagiri, Vandana, absolutely right. Absolutely right. The correct answer is loss of antithrombin. I told you that in nephrotic syndrome, many proteins are lost in urine. Many proteins. So the concentration of many proteins in the blood will fall. So I have given you the list. So albumin is the most common protein which is lost and that's why less concentration in the blood. Apart from albumin, it is immunoglobulin, it is transferrin, it is thyroxine, it is ceruloplasmin, but the main protein is antithrombin 3, which is lost in urine. That's why blood concentration of antithrombin 3 is less. That leads to blood hypercoagulable. Only one protein increase in blood. The answer is fibrinogen, and the reason is liver compensation. The fibrinogen. So these are the two reasons of blood hypercoagulable in nephrotic syndrome. Loss of antithrombin in the urine, so less antithrombin in blood, because it is lost in urine, and increase fibrinogen in the blood. So यहाँ पे loss of antithrombin तो सही है, decrease की जगह अगर इसको increase कर दूं मैं, if it is increased fibrinogen, so this option will also become correct. So it is decrease antithrombin and increase fibrinogen. These are the two reasons for blood hypercoagulable. Everyone give me a thumbs up. And you all are right. Very good, very good. Deepam, Malik, Abdullah, every good. Balaji, everyone is correct. So moving ahead to the next question. This is the next question in front of you. Now please read the question. All of the following are decreased in nephrotic syndrome except. The question contains except. So one of them is not decreased, it is increased. So tell me one protein which is increased. Rest all will decrease. I taught you specifically the name of the one protein which is increased in nephrotic. Rest all are decreased. Who will tell me the answer of that protein? Is it transferrin? Is it fibrinogen? Is it ceruloplasmin? Or is it albumin? Yes. Yes, Saima, Yadagiri, Deepam, Siddhika, absolutely right. The correct answer is fibrinogen. So only fibrinogen increases in blood. Rest all decrease. The reason for fibrinogen increase is the liver compensation. Liver try to compensate the protein loss, and liver can increase only one protein, fibrinogen. Rest all will be lost in the urine and liver cannot compensate it. So correct answer here is B. Yes, absolutely right. Okay, I'm sorry. This is the next question. What is the reason for edema in nephrotic syndrome? Specific question, specific answer. Don't confuse, don't do mistakes. Specific question, specific answer. Reason for edema in nephrotic syndrome. I'm not asking nephritic. I'm asking nephrotic syndrome. What would you like to say? What would you like to say? Yes, Balaji, absolutely right. What about others? What is the correct answer? Is it sodium water retention? Is it increased venous pressure? Is it hypoalbuminemia? Is it hyperlipidemia? Yes, absolutely right. Yadagri, Saima, Siddhika. It is hypoalbuminemia which decreases oncotic pressure. So decreased oncotic pressure due to hypoalbuminemia is the reason for edema in nephrotic syndrome. The same question. I am changing the question. Now you tell me the answer. Abhi to answer C hai. If this is the question, answer is C. I am changing nephrotic to nephritic. I am changing the spelling. Nephrotic ko bana do nephritic syndrome. Now what is your answer from ABCD? Who will tell me the answer? Change the question from nephrotic to nephritic. Now this time what is your answer from ABCD? I am just changing O to I. जरा सा चेंज कर दिया मैंने क्वेश्चन में स्पेलिंग में. I changed O to I. I changed nephrotic to nephritic. Now what is the answer? Answer will change. So answer in this case scenario will be A. You all are right. Absolutely right. Very good. In this scenario, answer will become A. So depending on the question, what is your answer? It depends, right? So correct answer here is C if it is asked for nephrotic, right? Okay, the next question is in front of you. What is the most common cause of nephrotic syndrome? Nephrotic syndrome, most common cause of nephrotic syndrome in adults, not in children. In adults, nephrotic syndrome in adults. So yes, you all are right. In adults. In adults, the answer is membranous glomerulonephritis. Again, I am changing the same question. Instead of adults, I am asking children. So most common cause of nephrotic syndrome, but not in adults, but in children. What is your answer now? What is your answer now? In children, it will be minimal change disease. Very good, Deepam. Very good, very good. So if I ask adult, answer is A. If I ask children, answer is B. So you can say by changing the question how the answer will become changed. So same question is asked. Most common cause of nephrotic syndrome in children. So answer will become B this time. I've already asked this question, right? I am done with the overview of glomerulonephritis. This was episode 1. Right. Now I will teach you the primary glomerulonephritis, which are 9 in number. We have already seen the classification. They are 9 in number. I will teach you all 9 in a comparative way. No one in this world will teach you in such a beautiful comparative way the 9 type of glomerulonephritis. Right. First, I will teach you APGN, acute proliferative glomerulonephritis or post-streptococcal glomerulonephritis. Then I will teach you RPGN. Then I will teach you MCD. Then MGN. Then MPGN. Then focal segmental glomerulonephritis, focal segmental glomerulonephrosis, then IgA nephropathy, then chronic. So these 9 I will teach you under following headings. I will teach you etiopathogenesis of all of them, then the gross feature, then 3 microscopy. In renal biopsy, we always say 3 type of microscopy: the light microscopy, the electron microscopy, the immunofluorescent microscopy, right? So you have to fill this table with me. Here you have to draw the flow charts. Here you have to draw the diagrams, the 3 type of diagrams you have to draw, right? With this, it will require the next 2 hours. In the next 2 hours, we will finish all primary type of glomerulonephritis in a beautiful comparative manner. So I request all my dear students to take a big sheet and divide the columns, the 9 columns like this and 5 columns like this. And one more you can add here, the clinical features. In the clinical features, you have to write either nephritic or nephrotic. I've already taught you which of them are nephritic, which of them are nephrotic. Now you know the meaning of nephritic, nephrotic. So add one more column here. So in this way, I will complete the 9 glomerulonephritis. Are you people with me? But you have to give me a break for the 15 minutes. And after 15 minutes, join episode number 2. So give me a minute. Let me announce my next class. Then you people can go for a break of 15 minutes. Then we will connect again. Okay, just a second. So here I am. So, okay, my next class is just after 15 minutes, right? That is sharp 10 a.m. right now. Sharp 10 a.m. right now, just after 15 minutes, join episode number 2 of Renal Pathology Glomerulonephritis. It is episode number 1 currently going on since last 2 hours. For the next 2 hours, we will connect on episode number 2 from 10 to 12. In 10 to 12, I will cover all primary glomerulonephritis. I want all the students to come back. Where is the class? It is on the same YouTube channel where you are attending now. That is Unacademy Live. You all have to come back on the YouTube only, on the same YouTube channel. You will find me live after 15 minutes, right? Now, there are few announcements for you. On Unacademy, 2023 NEET PG batch is already launched. If you take the subscriptions, you will be eligible for the repeaters batch, for NEET PG 2020 freshers batch, right? On Unacademy, we have 5 types of subscriptions available for the student. The plus subscription, in which you will be get only Unacademy live and recorded lectures. In Iconic, along with Unacademy, you will be having prep ladder recordings also. In light subscription, you will be having only test series. In MBBS Prop 1, you will get batches for anatomy, biochemistry, physiology only. And in UPSC CMS subscription, you will be getting UPSC preparation batches, right? You can see the various plans along with various prices, various duration in each subscription. Whatever plan fits to you, you can take that plan, you can purchase that plan. You can notice one thing, longer the plan, cheaper it is. So if you are a first prof, second prof student, go with 4 year, 3 year, 2 year, per month wise, it will be cheaper. But it's up to your choice, according to your wish, requirement. If you want to take any of these subscription, you are most welcome. If you are not sure, you can take as small as 3-month subscription for a trial, right? Whatever subscription you are planning to take, before payment, please apply my code Sachdev10. My code is SACHDEV. That is my surname. I am Dr. Priyanka Sachdev. So Sachdev is my surname without space 10. So this is the code. If you apply my code on any of this subscription, you will get straightforward 10% discount if you apply it before payment. Thank you very much. I want all of you to join me back at 10 a.m. right now for episode 2 of Renal Pathology. Bye-bye. I'm ending it.